opinion. And we are really greatly honored to have nobody better than the world than David Kuta, who is going to talk to us regarding this topic. He is probably the most experienced person in this field. So it's going to be, he is actually, unfortunately, has got a bit of a cold, so we will excuse him if he has to, in between, escape for a short period of time. We will do some questions. So we have a very good evening. We have case presentation as well as a panel discussion. And we're also privileged to have people from all over the UAE as well as from Qatar, Dr. Muhammad Yassin. So can you go back, please? The program will be starting with updates in treatment of ITP, then redefining early ITP. What is early ITP? What is chronic? The role of romiplastim in early ITP, then followed by the case presentation and panel discussion. Housekeeping notes, please use the Q&A panel to submit your questions. It is located in the top right. If you have any technical issues, just use the chat box and we'll have somebody try to assist you. At the end, don't forget, please, to complete the evaluation form so that we can give you your CME as well. So without wasting time, we will go to the updates in the treatment of ITP, and then Dr. David will continue with the other topics as well, redefining early ITP and the role of romiplastim. So David Kuta is the Director of Clinical Hematology, Professor of Hematology, Massachusetts General Hospital, and Boston, USA, and Harvard University professor. Please, David, welcome.
Thank you. Let me share my screen first in typical Zoom fashion. This will happen in about 10 seconds here. So I hope you can see my screen and hear my voice, but it's very nice being with you this evening. It's nice to see so many colleagues in the Middle East who I've met many times before, and I wish I was with you in person, but we live in a world that we live in. I shall also comment on two things. First of all, Boston right now, it's about 10 o'clock in the morning, and we're going to get a meter of snow today in winds of 100 kilometers an hour. So if I look out the window, it's because the house may be shaking where I'm lecturing you from. Second of all, my voice has been challenged this week, and if I start running out of voice, I'm going to ask us to take a couple questions and I'll resume my talk. But these are my disclosures. I work with many groups that develop ITP therapies and do a lot of research on this topic. I'm going to talk to you about many different uses of thrombopoietic agents, but I'll give you the Amgen disclosure since Amgen helped arrange this. You can see before you that the products we're talking about may not be licensed in your countries. But again, this is something I was asked to add to our discussion today. So I'm going to try to accomplish a lot of different goals today, and the structure of my talk is going to be to make it a unified talk, not different sections, but I'm going to try to cover different things. I'm going to try to talk about early ITP since that's a vague topic. I'm going to talk about I should say less recent, but the up-to-date ASH guidelines. I'm going to talk about the data that support using TP receptor agonists early in ITP. I'm going to talk to you a bit about what ITP remission might be and whether there's any data for it. And then I'm going to talk about some interesting new advances in ITP, some of which are published and some of which were presented at ASH. So I'm going to use today's session, if that's okay with you, as a modest ASH update describing what we learned and presented at ASH. So for those of you that don't do ITP a lot, we know this lovely old manuscript by Dr. Harrington. He injected into himself blood or plasma from ITP patients. His platelet count dropped to low levels and he got better. He was actually hospitalized here and almost had a central nervous system hemorrhage, but he was the guy who put on the map that something in the circulation caused ITP. Subsequent data by Dr. Schulman show that was an antibody. And what's happening here by this lovely electron micrograph is here's a macrophage. Here's an antibody-coated platelet, and it's being consumed by this activated macrophage. And we'll talk about new therapies and old therapies that inhibit macrophage phagocytosis a little later on in this talk. But basically, ITP is in part due to increased platelet destruction. And as many of you certainly know, there's also a problem of impaired platelet production, ITP. And we've all done bone marrow biopsies on patient ITP, and here's a megakaryocyte. We know that antibodies attack the megakaryocyte. We know that lymphocytes also attack the megakaryocyte, and the megakaryocyte undergoes programmed cell death or apoptosis, and that's why ITP patients don't produce platelets. So many of you have seen this electron micrograph here. This is from a PhD thesis a number of decades ago. This is a normal megakaryocyte, and this is a megakaryocyte in a patient with ITP, and this megakaryocyte's undergoing apoptosis. And indeed, if you do a bone marrow biopsy on an ITP patient and then look at the large number of megakaryocytes there, most of those megakaryocytes are dying, not living. And we know this also from very lovely data published by Terry Gernsheimer many decades ago that no one believed, but it's now believable, that if you have a normal person with a normal platelet count and a normal platelet survival of 10 days, that we are all making about 41 times 10 to the 9th platelets per liter per day. If you have ITP and a low platelet count, your platelet survival is about 2 or 3 days or less, and your production rate is also reduced by 50%. And this is data which was not believed back in 1989 when first presented, but we now believe this a lot. And in general, we now know that ITP is a disease of decreased platelet production. And this is a cartoon which I think many of you have seen me show before. I'm making platelets in my bone marrow. They enter my circulation. After 7 to 10 days, these platelets die by programmed cell death throughout my body and are cleared. There is a lovely apoptotic clock in platelets that determines their survival. If I have an antibody against my platelets, they're consumed primarily in the spleen, but also liver, and we have increased rate of platelet destruction. And for many years, it was thought until 1989 that we compensated by making lots of platelets. This is not true. ITP is a disease of increased platelet destruction and an inappropriately low rate of platelet production. So there's an imbalance here of destruction and production. And this is the genesis of most ITP patients. We don't have the tools available to us to discern whether one patient has too much destruction or too much inhibition of production. Those techniques are not with us just yet. But some patients, I'm just going to say this anecdotally, are destroying too many platelets but don't have a major effect on production. Other patients have a massive effect on production and a modest effect on destruction. But again, we can't, with clinical tools, discern these two different pathways, but both are probably going on. Second of all, and this comes to some of the topics for this talk, we talk about early ITP and chronic ITP, and it's important to mention these are arbitrary distinctions from a study and a group that was done back in 2009. We've pretty much classified ITP as early, meaning newly diagnosed, which is months 0 to 3, and persistent ITP is months 3 to 12. And we've clumped these together for reasons I'll come back to. And then we've defined chronic ITP currently as ITP for more than 1 year. That's based upon these new guidelines. But before 2009, chronic was over 6 months. But right now, chronic is defined as over 1 year, and early is up to month 12. Now, does this make any sense? And the answer is, it makes a little bit of sense. There's no known pathophysiologic difference between early ITP and chronic ITP, except for one thing I'll show you in a second. Also, just from empiric data, patients who have disease more than 1 year tend to be more refractory to therapy than those with earlier ITP, and we'll show you some data for that. But there may be a pathophysiologic difference, and this leads to a concern currently as to whether we ought to be more aggressive in treating early ITP and try to prevent it from becoming chronic. And let's talk about epitope walking. What does that mean? This is a platelet, and platelets, as you know, have 3 major antigens or products on their surface. One is glycoprotein 1b2a, which binds collagen. The second is the 1b9 receptor that binds von Willebrand's factor, and then there's the 2b3 receptor that binds fibrinogen and links platelets to each other. So these are the 3 main antigens that we target with antibodies in ITP, and our group has done a lot of studies in this recently. And what's interesting is that very few patients, so this is 260 patients, very few patients have only antibodies against 1b9. No one had antibodies against 1a2a, and a modest number had antibodies only against 2B3A, but the vast majority, half of our patients were triply positive for antibodies against all three antigens. And coming back to what epitope walking means, we then found some patients who we did multiple assays on. And we have, for example, 3 patients here who initially had only glycoprotein 2B3A, but after 12 months, they progressed to have antibodies against the other 2 major antigens as well. Other patterns were singly antibody against 2B3A, and then they acquired other antibodies after a number of months, and by 13 months, they also were triply positive. So this is what's meant by epitope walking. It is entirely possible we have mild disease here that becomes more aggressive here. Again, this is a rough guess as to what's going on here, but early ITP, I think, chronologically does differ a little bit from later ITP, and we can't tell you pathophysiologically how much the difference is there. But this is my attempt to show there is a difference between early and chronic ITP in the extent of antibodies on the plated surface. So having given this as an overview for those who don't see a lot of ITP to what ITP is, how do you treat ITP? You can either reduce the rate of platelet destruction, or you can work on the rate of platelet production. In white here are things that alter the rate of platelet destruction. You can reduce the IgG by, for example, rituximab or mycophenolate. You can block FC-mediated clearance by IVIG or anti-D or things like that. You can simply take out the spleen, or as they do in Japan, embolize the spleen to reduce splenic function. I've talked to you in the past about ways to increase platelet production by a TPO receptor agonist. I will simply comment that corticosteroids also increase platelet production somewhat, as I'll show you momentarily. And the drug dapsone may have a modest effect here as well. But basically, these are the 2 major modes of action for treatment of ITP. Together, they may work better than having an attack on production or an attack on destruction. As you are all familiar, since you take care of this disease, the typical therapeutic course, and I'll come back to this in more detail in a second, is to give a patient initial therapy, corticosteroids or IVIG. And I'll come back to a new approach to ITP, which is to add newer therapies, mycophenolate, rituximab, or thrombopoietin to the therapy to see if we make the early disease become no longer chronic. But I'll return to this in a few minutes. But the standard initial therapy is corticosteroids and IVIG, and these tend to work in a large number of patients, probably 80% of patients. The real problem that we all face, and I've talked to a number of you about your own patients, is subsequent therapy. So when the patient responds to IVIG or corticosteroids, we want to wean them off these medications and the disease relapses. And this leads us to subsequent therapy, which has historically been splenectomy, rituximab, and now thrombopoietin receptor agonists. And I should answer a lot of other therapies, mycophenolate, fostamatinib, danazol, DAPS. The list is very long here, and I'll elaborate on this list in a few minutes. But this is the standard course. And I'm going to simply say that we won't talk much about initial therapy. This is pretty much standardized throughout the world. I'll come back to whether we should be more aggressive in initial therapy in a few minutes. And the major discussions are, what do you do? Splenectomy, rituximab, or thrombopoietin receptor agonist, or something else to treat the patient who's got disease that hasn't disappeared after 3 to 6 months. And let me just briefly go over these forms of therapy since you all know them, but I'm going to provide a little bit of newer data for several of them. So the first statement about a method is taking out a spleen and creating asplenia works, but it does have some side effects. And I think you're all familiar with this old data that's been published many, many times, that if you take patients with ITP and within the first 3 to 6 months take out the spleen, there's an 85% response rate that remains at about 65% by year 10. So this is an effective therapy. It works most of the time. I will simply say that if you use splenectomy in the first year of ITP, a third of the patients that you splenectomize probably would have gone into remission had you not taken the spleen out in the first place. And we'll come back to that discussion in a few minutes. But this is old data that used practices from the 1950s and 60s and 70s where splenectomy was the first therapy. Now, I'm going to update you a bit, since this is part of my talk, is to provide you new data. There is a very nice manuscript that was published a week ago in the American Journal of Hematology. And this is the ASH abstract presentation as an oral abstract 17 at ASH. This is from my dear friends in France, and they have done a very nice study asking whether splenectomy is still relevant in treating ITP. So they start with this lovely paper, and it says that they comment that thrombopoietin receptor agonists and rituximab are declining the use of splenectomy. But in France, they ask, well, is splenectomy still working? Does it still do what it's supposed to do? And the second part of the study was, if a patient fails splenectomy, do the TPO receptors still work? And so they did a retrospective analysis between 2011 and 2020 of patients with ITP who had had a splenectomy. And then they used response criteria. And I'll simply say that the standard response criteria for ITP is a complete response is a platelet count over 100,000. A partial response is over 50,000. And if it's over 50,000, it's over 50,000, under 100,000, this is called a partial response. So what they showed is that if you look at patients who responded to splenectomy, they found that 77.8% of patients responded to splenectomy in this study. If you then follow these patients, 64% maintained a response for at least a year or year and a half. And so basically what they found is the initial response rate was 78%, comparable to the 85% I showed you in the prior old data, and a sustained response was 65%, identical to the old data. So splenectomy still does work, even in patients who've had a prior thrombopoietin receptor agonist or rituximab. And the patients studied here weren't patients who necessarily failed these agents, but they're patients who tired from being on these agents and then got splenectomy. Now, they also highlight something very interesting. If a patient failed both thrombopoietin receptor agonist and rituximab, would that patient still respond to splenectomy? And what they showed is that half of those patients respond to splenectomy. So in a situation where patients don't respond to standard medical therapy, there is a role, and we'll come back to what that is in a few minutes, for splenectomy in this patient population. The last thing they showed was an interesting concept. They looked at patients with ITP who had failed a thrombopoietin receptor agonist, and there were 43 of them. These patients then went on to get splenectomy. 21 patients still didn't respond to splenectomy. And they asked, well, if they failed a TPORA, will they now still fail a TPORA? And they found that 2/3 of patients now responded to a TPORA who had previously not responded. And this goes along with old data that splenectomy may make old therapies that didn't work now more effective. So this is the update for splenectomy. Let's return to old data in splenectomy and talk about the kinetics of platelets. I showed you before that we have a normal platelet survival 9 days or 10 days, and we produce platelets at a normal rate. If you take patients prior to splenectomy, their platelet counts are low, that 123,000, they're on prednisone here. If you then take out the spleen, their platelet counts rise excessively, as you all know, and the platelet survival goes from 2.9 days to 9 days. And this is basically by taking the spleen out, you increase the rate of platelet survival. Another thing you do with splenectomy, and I'm not here to advocate splenectomy, I'm simply saying that there is data to support its use, is this is another bit of data from a French group, and they actually looked at the spleens that were taken out of patients, since splenectomy is still done until recently commonly in France. If you have a patient who had ITP and then had a splenectomy and had no prior rituximab, a lot of short-lived plasmablasts making antiplatelet antibodies were removed in the spleens of these patients. Furthermore, if you'd failed rituximab with your ITP, what they found in the spleens is they found lots of long-lived plasma cells that were making antiplatelet antibody. So by taking out the spleen in these rituximab refractory patients, they'd actually taken out the site of major antibody production for ITP. And that's why 70% of these patients responded to the splenectomy. But this is good data. The negative data comes next, which is that there's an increased risk of thrombosis after splenectomy. These are ITP patients without splenectomy, a modest rate of thrombosis. If you take the spleens out, there's a 3 to 5-fold increased rate of thrombosis in the patients with splenectomy. This is true for many other indications for splenectomy, as well as I'm sure you all know. You all know that if you take your spleen out, there's a higher risk of infection. These are ITP patients who don't have their spleens taken out, and these are asplenic ITP patients, a 1.5 to 3-fold increased rate of infection after splenectomy. Finally, these reasons for not taking out the spleens have led to a dramatic decrease in splenectomy rates. Notice this was happening before 2009 when the TPRAs came in. This curve has recently been updated. It's not been published, and the rate of splenectomy in North America has dropped off. It's not zero, but it's probably under 5% right now, probably because the TPRAs and other agents have been so effective in treating ITP. So that's an overview, both an old review and an update of splenectomy. Rituximab we've used a lot in ITP. It has never been proven in a randomized prospective study to be effective, but it's used by many of us, including me. This is a meta-analysis of studies where rituximab has been added to standard of care. There are at least 5 studies, all small patient numbers. And in general, if you look at a complete response, a platelet count higher than 100,000, there were more patients with rituximab that attain that than those who are on standard of care. So there's a 47% complete response rate with rituximab added versus 33% if you didn't have rituximab. So this is one thing in favor of rituximab early in the disease course, and I'll return to this. But partial responses, platelet counts that are over 50,000 but not above 100,000, were pretty much the same. 58% with rituximab, 47% with standard of care, which is usually corticosteroids. Furthermore, bleeding rates were the same, 9.2% versus 5.2%. No p-value is not significant. And finally, the infection rates were a bit higher, but not statistically significant with rituximab. So the conclusion of this meta-analysis, which has now been done by our group as well with other studies, is that there's little evidence for a sustained response beyond 6 to 12 months. So basically, the use of rituximab, which we hope would cure the disease, may enhance the early response, but not in a significant way. And this is why the ASH guidelines, as I'll come to in a few minutes, did not include rituximab as an initial form of therapy for ITP. And this is the data. There's a 57% initial response rate to rituximab that declines to 39% by 1 year in adults, and by 5 years is 21%. Now, we've had a little discussion before this lecture started, and if you respond to Rituxan once, you can give it again and again and again. There are some negatives for doing that, but we can discuss that in our question and answer session. But rituximab does remain an acceptable form of therapy for patients with ITP. Which brings us to the third line of discussion, which is the use of the thrombopoietin receptor agonist in ITP and a wide variety of other thrombocytopenic disorders. As you know, there are now 5 TPO receptor agonists. There's romipilstim, L-trombopeg. The newer one, I think we've talked about this in prior lectures, avatrombopeg, lusotrombopeg, and the one in China, which is being developed a lot, is heterotrombopeg. This was just licensed in China, I believe, last June for treating ITP. How do TPO receptor agonists work in ITP? Quite simple. This is that megakaryocyte in the bone marrow. It's being attacked by antibodies, being attacked by lymphocytes, and it's undergoing programmed cell death. If you give that megakaryocyte a thrombopoietic agent, it binds the thrombopoietin receptor megakaryocytes. This reverses the apoptosis. The megakaryocyte then lives and it generates platelets. So one of the things is that, can we prove this? And the honest answer is we've proven it in 2 or 3 clinical studies. And I'll simply cite one clinical study. This is a study with the newer drug avatrombopeg, which, as I'll show you, is an oral thrombopoietin receptor agonist. If you have a patient with ITP at day 1 and give them a stable dose of avatrombopeg for this entire study, there's a rapid rise in platelet count, which on the same dose of the TPO receptor agonist then declines. This is a rapid rise in platelet production because all those megakaryocytes, which were programmed to die, now live and give this huge surge of platelets. And this is sometimes very confusing for clinicians. So if any of you have had this situation where, oh my goodness, you gave a thrombopoietin receptor agonist and the platelet count then rose too high for your comfort to 600,000 a week or 2 later, don't get excited. keep them on the same dose of the thrombopoietic agent, because invariably this is a first dose effect, and the platelet count tends to fall off thereafter. This is true for, we've shown this for Mipplestim, L-Trombopeg, and Avatrombopeg. So going back to my cartoon version of a muscular young person, we make platelets. They then are destroyed by ITP. We thought that the bone marrow compensated, but it didn't. And now we give a patient with ITP a thrombopoietic agent. And what happens is the rate of platelet production rises and the platelet count rises in the circulation. Note that thrombopoietic agents don't seem to have an effect upon platelet destruction. You're simply ramping up, for most patients, the rate of platelet production. So going back to how the thrombopoietin receptors work, I will simply say briefly, and I'm not going to spend a lot of time on this, that the TPO receptor agonists have different mechanisms of action. The Mipplestim drug binds to the native receptor here at a distal cytokine homology region and activates the signal transduction pathways. The other agents, which are oral, L-Trombopeg, Avatrombopeg, Lucitrombopeg, Heterotrombopeg, bind in the transmembrane region. There are slight differences in how they do this, but the net result is that both types of molecules, Mipplestim and the oral agents, increase megakaryocyte growth and increase platelet production. Now, again, I'm not going to spend time going over these different agents since they're familiar with many of you. I'm going to simply take you as a brief guide through these agents. Mipplestim, L-Trombopeg, Avatrombopeg, and Heterotrombopeg are all approved in different parts of the world for ITP. They have different mechanisms of action. Mipplestim binds, as I said, to the distal part of the receptor. The other three bind to the transmembrane receptor. Interestingly, L-Trombopeg chelates iron dramatically and may even cause iron deficiency in some patients. The others don't seem to do that. L-Trombopeg has a bit of off-target effects, which I think are not important, but that's been shown in a number of studies. The major differences are the following: that Mipplestim in healthy subjects is a much more potent drug than is L-Trombopeg. Avatrombopeg is more potent than L-Trombopeg. The newer drug, Heterotrombopeg, is somehow between these two. So this is potency in healthy volunteers. That is not translated to potency in ITP. So in ITP, this potency difference probably is of no difference. Mipplestim is a sub-Q drug. The other three are oral drugs. L-Trombopeg and Heterotrombopeg have dietary restrictions. Avatrombopeg and Mipplestim don't. There are concerns about East Asian ancestry and liver dysfunction that occur with L-Trombopeg and with Heterotrombopeg, not true with Avatrombopeg or Mipplestim. L-Trombopeg increases LFTs, the other three don't. Renal failure, I've actually used all of these drugs, and this is now, I have done this as well in China in a study we run there. They're probably fine in renal failure. I don't advocate any of these in pregnancy, but there's new data presented at ASH that I don't have time to go over that says that Mipplestim seemed to be doing well in pregnant patients where desperation was the reason for using the drug and didn't seem to have any detrimental effects upon the pregnancy. So I don't have time to talk about that, but I'm happy to answer questions. So coming to the TPO receptor agonist, I will simply say that in my view, there's no difference in response rates of Mipplestim, L-Trombopeg, Avatrombopeg, Heterotrombopeg, and ITP. In North America, the choice of the three agents we have, which is Mipplestim, L-Trombopeg, and Avatrombopeg, is based upon patient preference, but mostly what their insurance covers. So that's how we determine this. So the question comes is, what's the summary data? I'm now going to summarize 125 manuscripts, of which we published half about TPO-RAs and chronic ITP, and say that in general, the response rates are over 80%. The responses are sustained. Dosing is usually stable. They reduce the need for rescue medications such as IVIG or prednisone. They reduce bleeding. They improve health-related quality of life. They can reduce the need for other ITP therapies. You can avoid splenectomy for most patients with these. Side effects are minimal. The platelet counts may not be totally stable every week, but like many other people, they will bounce around a fair amount week to week, but that we want to select a range of platelet counts between, say, 50 and 150,000 as our platelet range. They may promote remissions. I'll come back to that. The major problem is they are not cheap molecules to use. Let me briefly show you data to support a few of these points, and I think much of this data is familiar to you, so I'm not going to spend a lot of time on it. But basically, this is data we showed for Remipulstim. Placebo patients didn't respond. Almost all patients who got Remipulstim had a rise in platelet count within 3 or 4 weeks to a stable range over 50,000 and did well. Furthermore, if you compare those that got Remipulstim versus placebo, the overall response rate was 83%. Rescue medication need dropped a lot, and the patients could quite commonly discontinue their corticosteroids. We've shown exactly the same thing with L-Thrombopeg and Avatrombopeg, and the Chinese have shown the same with Heterotrombopeg. We've gone on with Remipulstim, which is the only example I'll use here, is that if you are on Remipulstim, your need for splenectomy tends to disappear, whereas with off Remipulstim, this is a 3-continent study, 3 different continents, the need for splenectomy was 21% after 1 year. I didn't talk much about quality of life, but using the thrombopoietin receptor agonist, health-related quality of life tends to increase. And this is a study, again, with patients on one of our studies, comparing standard of care with Remipulstim. And in general, many of the fields that are tested for had a significant benefit by being in Remipulstim versus standard of care. Health activity and overall fear of bleeding dropped enormously when you're on Remipulstim. This is also true for the other thrombopoietin receptor agonists. And finally, all of these drugs have been shown to be effective for up to 5 years. We've actually got some patients out 10 years on these drugs, but as I'll come back to, most patients don't need these drugs for 10 years or 5 years. They go off them very fast. So I will simply say this is a study. Again, we've only got 9 patients out of 5 years here, but this is a study for Remipulstim, a stable dose and a stable platelet count for up to 5 years in the few patients who required therapy that length of time. So you know all this stuff already, I'm sure. How do we put this all together? And this is where guidelines help. And as I've said to many of you before, it's nice to have guidelines that are region specific. There are Japanese guidelines. I've helped develop the Chinese guidelines. There are European guidelines. There are international guidelines and ASH guidelines. I think there ought to be Middle Eastern guidelines, which I would encourage you to work together to create. Maybe you have already done this. I'm going to focus on the ASH guidelines, which took 5 years to generate, to my surprise. They're probably a bit out of date right now, and I'll come back to why, from 2019. And I'll summarize what they said. This is a 185-page article that was published in Blood Advances with a lot of supplements to it. For initial therapy, and this is something which is pretty much standard already, no need to admit the hospital unless the patient counts are below 20,000. And if a patient is someone you already know, even at less than 20,000, there may be no need to admit the patient to hospital. If you're going to treat a patient, we recommend treatment under 30,000, and the corticosteroids are the preferred form of therapy here. I would also say that my own personal preference is 20,000, but the guidelines said 30,000. The guidelines didn't think that the data for adding a second agent to initial therapy was robust enough. I think that if we go to future guidelines, that may not be the position. They advocated a short course, and this comes back to our part of our discussion about early ITP. They recommend a short course of corticosteroids of 6 to 8 weeks, including tapering, and they didn't have any preference of prednisone versus dexamethasone in treating this patient population. So this is the initial therapy. I'll return to some of these points with newer data in a few minutes. The major controversy, I think, for the ASH guidelines was something that was set up that wasn't discussed by the guidelines writer or necessary evidence-based. They postulated an adult with ITP for more than 3 months who was corticosteroid dependent or had failed to respond to corticosteroids. So they pushed back the discussion as to what you do now that we recommend steroids for no more than 3 months. What do you do at 3 months? Do you keep on corticosteroids, or do you try other medical therapy or surgical therapy? And here's where the guidelines committee created a bit of controversy. They compared thrombopoietin receptor agonists to rituximab, and they favored in this situation at 3 months to use a thrombopoietin receptor agonist. They then said, well, would you rather in this situation use rituximab or splenectomy? And they said, we prefer rituximab. And then when it came to the obvious next discussion about splenectomy versus a thrombopoietin receptor agonist, they were unable to make a statement. And out of respect to the group I was part of, it's because there are no studies to guide us as to what the appropriate therapy is. So we're left in a situation where a thrombopoietin receptor agonist is better than rituximab. Rituximab is better than splenectomy, but we would have thought that the thrombopoietin receptor agonist would be better than splenectomy, but that was not answered by this guideline group. So this leaves us with a bit of a controversy at 3 months. What do you do? TPRA, rituximab, or splenectomy? And the guidelines say it doesn't really matter which you do, but they also strongly said, and this is what this asterisk here, use medical therapy for at least 1 year before considering splenectomy. So they said, delay this decision. So at the 3-month mark, you're sort of left with this discussion of thrombopoietin receptor agonists versus rituximab. So why did they want to put off splenectomy? They did it because of a lot of data. I'll show you some more data in a second that says that many adults, not quite as many as children, have a response if you just wait. And basically, this is a lovely old study from Ingrid Pavinger in Vienna, and we have replicated this in Boston as well, that if you don't do splenectomy, some 75% of patients will have a response, a platelet count at least over 30,000 without splenectomy at 9 months. A complete remission, platelet count of 100,000 in 40% of patients at 6 months. So this is one of the bits of data that colored the ASH Guidelines Committee to say, if splenectomy is going to be thought about, think about it later on. So we have a 2-tiered approach to ITP right now based upon these guidelines, which is, or I should say 3-tiered approach. Corticosteroids are something for about 3 months, then stop them. If you don't have a remission, then you've got to consider usually rituximab or a TPO-RA. And then at the 1 year mark, approximately, one then considers splenectomy. I'll go over this algorithm in a few minutes as well. So the real question that should be asked if we are going to recommend a TPO-RA, is there any evidence that at month 3 or even earlier that a TPO-RA works? And I'm going to cite to you an extensive amount of data which colored the Guidelines Committee's recommendation. I'll show you a retrospective analysis of 9 romipilstim studies. I'll show you an upfront study with romipilstim. I'll show you a upfront study with eltrombopag. And then if there's time, I'll show an upfront study with recombinant thrombopoietin. I don't have time for the 20 other studies that show that there's evidence for using a TPO-RA earlier in ITP, even though until recently these drugs were only approved for chronic ITP. So this is a pooled analysis of 9 romipilstim studies that we did with ITP. There are 311 patients who had ITP for under a year. Half of these patients had ITP for under 3 months. The other half had ITP for 3 to 12 months. And we're comparing this to 726 patients who had ITP for more than a year, at which time we added a thrombopoietin receptor agonist, in this case, romipilstim. I will simply say that the median ages were about the same for all these patients. Baseline platelet counts are pretty much 18 to 20,000. ITP duration here was 1.2 months, 5.8 months, and here it was 72 months, obviously, because they had disease for a longer period of time. Prior therapies, more than 3, a small percentage for the early groups, 22% of patients for the other groups. And splenectomy is much more commonly seen in the patients with more chronic ITP. So we're basically comparing chronic ITP to early ITP. So the question here is, does romipilstim make a difference, whether it's early or late ITP? The answer was no. You have the same response rate, meaning platelet count rise over 50,000 with early ITP, which is the blue bars, versus chronic ITP, the gray bars. And this was true for up to 160 weeks of therapy. What about the frequencies of response, meaning a platelet count over 50,000? Well, if you have early ITP, you responded more than 75% of the time with equal frequency, whether you had early ITP or late ITP. If you discuss who had a response more than 90% of the time, it was the same early ITP versus late ITP. We created this little somewhat ridiculous thing of a durable response, which means a response on 6 weeks of the last 8 weeks of the study. Again, similar response rates, whether you had early ITP or late ITP. So the platelet count response you get in early ITP is identical, maybe a tad better, but not statistically so if you use the drugs in early ITP. What about corticosteroids? Again, blue is early, gray is late ITP. The use of corticosteroids dropped for both groups to the same extent. And finally, what about grade 2 bleeding or greater? Again, bleeding rates dropped equally good or well with early ITP and chronic ITP. So this data from a large data set shows that early ITP and late ITP have the same response to TPRA. So this validates to the ASH Guidelines Committee the recommendation that TPRA could be used early in the disease process. Finally, what about negative effects? And thrombosis rates occur in ITP, as you all know. And what's interesting is if you look at the thrombosis rates, they occur whether your platelet count's under 20,000 or over 400,000. There is no association whatsoever of thrombosis with platelet counts in ITP. And whether you had early ITP or late ITP, the thrombosis rates were actually, to surprise, a little higher in the chronic ITP than in early ITP, but that was not statistically seen. When you look at the larger patient numbers out here, the rates of thrombosis were the same. They were still incredibly low rates. That's the first bit of data that suggests that chronic ITP and early ITP can be treated with equal efficacy with using a TPO receptor agonist. There's another study. This is a study done by my dear friend, Dr. Newland in London. He took brand new, freshly diagnosed ITP patients, gave them all Remiplastim for 12 months. When their platelet counts went over 50,000, he then tapered them off of the Remiplastim and asked, was a remission attained? And a remission is defined as a platelet count over 50,000 that lasts for more than 24 weeks. And what was interesting is this: if you look at early ITP, which is these are all brand new patients, the initial response rate was 93%. That response rate occurred at a median of 2.1 weeks of therapy, so the responses are very rapid. And then if you ask who could come off a thrombopoietin receptor agonist by 1 year, 32% came off the thrombopoietin receptor agonist, and this occurred after a median of about 27 weeks of therapy. So it comes back to this discussion that a third of all patients who have new ITP that are treated with a TPRA will then have remission at 1 year. Whether this is due to the drug or just supportive care for that length of time is a discussion point for later on. Here's the rate of remission rates here. By 1 year, 32% of patients enter remission. And here's the platelet counts. These are the 24 remitters. They attained an average normal platelet count here with no drug being given. These are those who had no remission, but maintained a stable platelet count of about 100,000 on a stable dose of Remiplastim. So again, this shows that remissions occur in about a third of all newly diagnosed patients. Hence, it pays to do something medically to support them at least for a year to let that remission rate occur. Again, whether that remission is due to the Remiplastim or simply due to the fact that the autoimmune disease got better is an interesting discussion point. Now, is this true just for Remiplastim? No. This data has been shown for all the other thrombopoietic agents. This is a study which was recently published by my colleagues in China. They looked at L-Trombopeg, and basically they took brand new patients and gave them at week 1 L-Trombopeg or dexamethasone pulses for 12 weeks. So they got treated only for 12 weeks with L-Trombopeg, and pulse steroids as necessary. The response rate was 88% to the combination of L-Trombopeg plus dexamethasone. They then came off all therapy here, and the question was, what happens for the next 6 months? Was there a durable response? And what they showed is that the 44 patients who initially responded, 26 maintained that response, 57%. So this gives you a higher rate than the British study with a response rate of 32%. We now have a 57% response rate in these patients that last. And this is their analysis here. This is the baseline platelet count of responders. By 3 months, they'd responded. They then came off therapy at this point and were monitored, and they maintained a basal platelet count. This is the average platelet count in the group right here. They maintained an adequate platelet count. not everybody was normal, but all were over 50,000 at 9 months, and again at 1 year. So this again shows a high response rate that's maintained with the omission, in this case, of continued therapy with any agent for this period of time. So this has led my colleagues and I, we published this in Blood a year ago, to sort of modify the ASH guidelines. And this is I want to say this needs to be a region or country-based algorithm, because I think this is still an expensive form of therapy for ITP, and I'll come back to that in a few minutes, but it's been our current algorithm for most of the Western European countries and for North America, but that if you have initial therapy, it's steroids and IVIG. If you're steroid dependent or unresponsive, we then switch to a TPO receptor agonist, usually early on at months 3 or 4. This will give you a response rate of maybe 90% of all patients here. About 10% of patients don't have a good response, in which case we will switch to rituximab, a different thrombopoietin receptor agonist, or the other drug we haven't talked about, fostamatinib. By switching at this stage, we'll probably have 95% of our patients under control. 5% who then don't respond well here can oftentimes be rescued by adding an immunomodulatory drug like mycophenolate or even low-dose prednisone, or go on to clinical trials. We have rarely recommended splenectomy, but in patients who do get splenectomy, we will pretty much insist that they first have a trial rituximab to see if they fall into that 21% of patients who have a good response to Rituxan. But this has been our current algorithm for treating ITP patients. It is not perfect, and it's not universally applicable. So let's talk about let's briefly digress for something interesting, which is new information. Do you have remissions with a TPO receptor agonist? I showed you before that with eltrombopag and with remipalstim, that maybe between 32% and 57% of patients at 1 year will have no need for therapy if you just support them with a thrombopoietin receptor agonist. This is another recent bit of data which was presented at ASH, which is called the STOP-A-GO study. This is horrible English and probably even worse in French, but basically these are my very dear French colleagues, and they have organized the entire country of France to do a study. And what they did, and this was presented at ASH a couple months ago, this is a prospective study, and this is a very interesting study, which I would commend my colleagues in the Middle East to repeat to see if it's true for you. They took ITP patients. Again, these are both chronic ITP and early ITP patients. These are patients who are on a TPO receptor agonist. If their platelet count was more than 100,000 for 2 months on a TPO receptor agonist, and they had been treated with that drug for more than 3 months and had not gotten rituximab or splenectomy. So this is a typical responder group of patients. They were enrolled in the study. Once they were enrolled, the thrombopoietin receptor agonist was tapered off over 10 weeks. And they asked, was the response maintained? And this is really interesting. These are all the responders here. So this is a responder analysis here. So this is at time 0, all the patients responded. And the question was, once you stop the thrombopoietin receptor agonist, does the response get maintained? And what they showed, and I apologize for this bad graphics, but they showed that at 24 weeks right here, 57% of patients maintain a platelet count over 50,000, and that 55% of patients, so half of this group, had a complete remission. If you go out to 1 year, which is out here, 52% of patients were able to maintain that. And basically what they showed is that half of the group where the drug was tapered maintained a platelet count over 50,000 at 1 year. This is a very high sustained response rate. And these are both early ITP patients and more chronic patients treated with a TPRA. And this mirrors our prior publications that shows that between 30 and 40% of patients who have chronic ITP on a TPRA, after anywhere from 6 to 12 months, will be able to come off. And in general, to summarize other data, which I don't have time to go into, probably 65 or 70% of patients who are started on a TPRA will come off that drug within 1.5 years. So let me digress. And this is where I would love sometimes to come back and talk to you about this area in greater detail, because there's a whole bunch of new treatments for ITP, which I want to spend my last few minutes talking to you about. In terms of early ITP, there is an increasing interest in adding new agents to early ITP other than steroids and IVIG to try to prevent early ITP from becoming chronic. I mentioned to you rituximab, and I won't talk about it a bit more. I will mention to you recombinant thrombopoietin, which I haven't talked all about, but this is available only in China. This is the old drug which caused antibodies in our studies two decades ago. I'll talk about mycophenolate, and I'll briefly talk to you about tacrolimus, which has another interesting new bit of data. So this is a publication from a year ago. This is a group from China that did something which, and I'm going to honestly tell you that I'm not totally trusting of the study, but basically they took newly diagnosed ITP patients. They were given 14 days of inpatient daily thrombopoietin, which is recombinant human thrombopoietin plus high-dose dexamethasone, and they were compared to patients who got high-dose dexamethasone. By day 14, those on the TPO agent had a much higher platelet count, 143,000 versus those on dexamethasone alone. And at 6 months, this is now off therapy, 51% had a higher response than those, had a response rate versus 30% of those that got dexamethasone. And this is the Kaplan-Meier analysis of responders. There is a slight advantage. Again, p-value of 0.04. You got to be careful about that. But basically, this suggests that adding a recombinant thrombopoietin, a drug available only in China and in the Ukraine, has maybe a potential benefit. This requires more study, and that hasn't happened yet. The agent that has had a lot of interest recently is adding mycophenolate to initial therapy. This is a study published in the New England Journal of Medicine by my dear friends in England. They took patients and gave them glucocorticoids alone or glucocorticoids plus mycophenolate. This is a randomized, non-blinded study. They showed there was no difference in platelet counts at 2 weeks with a platelet count over 30,000. No platelet counts difference over 100,000 at 2 weeks. There was a slight difference in platelet counts before a second-line therapy, such as a TPR, was given. But the major finding they showed was that if you look at long-term survival, those on mycophenolate did better. And this is a controversial paper, but I'll just show you the data. They show that if you add mycophenolate up front, that by 700 days, the median number of patients who did not require any other therapy was like 82% versus 55% of patients who got in the high-dose dexamethasone therapy. There are a lot of equivocations about this paper, but basically, this is a huge and interesting paper that suggests we might want to add mycophenolate or some other immunomodulatory drug to the initial therapy to try to make the early ITP not become chronic. Now, this brings me to the third ASH abstract I want to present to you, because this is an interesting molecule that you all know, tacrolimus. We've used a comparable drug, which is cyclosporin, in the patient with ITP for many years and have not studied it in a good way. But this is a nice study from my colleagues in Shanghai. They added tacrolimus to high-dose dexamethasone versus high-dose dexamethasone in first-line treatment of adult ITP patients. This is an open-label phase 2 study of initial therapy, again, focusing on early disease. Randomized, open-label, not blinded. They looked at newly diagnosed treatment-naive patients, platelet counts under 30,000. They allowed patients whose counts were under 50,000 with bleeding to enroll. This is a bit of a fudge, and I'll come back to that a little later on, but this is okay. High-dose dex, which is a form of therapy you all know, was 40 milligrams a day for 4 days, and they could repeat it once more if necessary. Then they added tacrolimus to the high-dose dex. The tacro was 0.3 milligrams per kilogram per day with levels of 3 to 5, which is a typical low dose for transplant patients. And this was given for 12 weeks. And their primary endpoint, and this is important to think about, was a good one, was the platelet count over 50,000 in the absence of therapy 6 months after the therapy was done. So a 12-week therapy course, you then follow them up for another 6 months. What happened? And this is really interesting. It requires validation, but it's interesting. There are 68 patients on high-dose dex, 72 on tacro. At 6 months, sustained remission, which is about what you might expect with high-dose dex, 43%. Adding tacrolimus went to 65%. This is sustained remission, again, means on no therapy at 6 months. It's tantamount to some kind of remission standard. If we just look at responses, platelet counts over 50,000, high-dose dex 56%, adding tacro, this rose to 76%. And then there's this concept of treatment failure, which I don't want to go into, but it simply means that did the therapy work or not? If it didn't work, you had to go on to some other agent like a TPRA. And they showed that the failures were 38% with high-dose dex, but adding tacrolimus dropped this to 19%. And the side effect differences, there is no difference in side effects of infection or things like that. So this is a very interesting study, hasn't been published yet. I'd like to look at the nuances of the study, but this suggests that we've got options for upfront therapy that may change. We may be adding rituximab. We may be adding a thrombopoietic agent. We may be adding mycophenolate. We may be adding a tacrolimus to initial therapy. These are all things for the future. I don't want you doing this just yet, but maybe soon. Let's finish on chronic ITP with novel therapies that are in the pipeline. And again, at some stage, we should maybe spend an hour going over the nuances of all these nifty therapies. I will simply say there are lots of new therapies in ITP, and I'm going to talk to you about 2 of them at the most if I've got time, which I think I do. I will comment upon a number of them, anti-CD38 molecules like daratumumab. There was a daratumumab study that we're doing in Norway that was presented as a conceptual abstract to ASH. There's some anti-CD40 antibodies which don't seem to work. There are things called immunoproteasome inhibitors, which are under clinical trials, no data yet. I'll talk to you about some other time the use of a neonatal FC inhibitor. These make the antibody level just drop by 80%, and they've been shown in a couple studies to be effective in ITP. There is a new form of IVIG where you hypersialate it or make FC multimers of it. These are very interesting new therapies for ITP. I'll mention to you in a few minutes a new SYK inhibitor. We do already have a SYK inhibitor called fostamatinib, which works quite well that does not work quite well in ITP with response rates of 20 to 40%. I'll talk to you about a new Bruton kinase inhibitor we're developing. This is, to me, the most exciting area, and I say it not because I'm biased, but I am. It's an area we've been working on. Atra has been conceived as being added as an anti-inflammatory drug for ITP. We've tested complement inhibitors. Recombinant human thrombopoietin has currently been used for 10 years for ITP in China, and it can be used in pregnancy. And at some later time, we'll talk about using low-level laser light to make your megakaryocytes make more platelets. That's a future talk. So let me present you a couple abstracts from ASH, and this will be my parting blow to you today. This is an abstract I was pleased to present with my colleagues, and I'll make it very brief. This is a Bruton kinase inhibitor called rilzabrutinib. You all know that BTK is necessary for B-cell maturation, and you use ibrutinib to turn this off to treat CLL. What's important to note is that the Bruton kinase is necessary for signal transduction for macrophages here to ingest platelets. We can inhibit SYK kinase, but we now have an inhibitor of BTK that will inhibit phagocytosis. This drug is shown here. This is the cartoon version of the drug. It binds to BTK, and this thing here is a disulfide region that improves its selectivity. The drug is in your circulation for a short period of time, but it inhibits BTK for an entire 24 hours. Remember that ibrutinib affects platelet function. Rilzabrutinib does not. It has no effect upon collagen aggregation. I should also mention this drug does not affect or cause atrial arrhythmias as ibrutinib does. We've taken patients with typical ITP. They required 2 platelet counts below 30,000, gave them different doses of rilzabrutinib, and asked, were 2 consecutive platelet counts over 50,000? If they were, they're a responder. If they did, they could go on to a long-term extension study. And what I want to show you briefly is that we have 60 patients. Some got lower doses of this drug, but most got 45 milligrams twice a day, which was a well-tolerated dose. They then, I'll show you data for this group of patients. These responding patients then went on to an open label study. 13 came from this group and 3 from these other groups. And we have 16 patients in an ongoing long-term extension study. So who are these patients? Those that were started on the 45 milligram, the highest dose, median age, a few more women than men. They'd had ITP for a median of 6 years with a median of 4 prior therapies and a median platelet count of 15,000, a highly refractory group of patients. What happened? 40% of patients had a response. 18 patients out of 45 had their platelet count rise over 50,000 for 2 consecutive weeks. That's shown here. These are the non-responders. If you look at the 24 weeks of the study shown here, the platelet count was over 30,000 on a median of 95% of the weeks on study. The platelet count here was over 50,000 on a median of 72 weeks of the study. So a very high rate of response that was durable. Furthermore, responses occurred first at 8.5 days. So we have patients that started to respond at 8.5 days with a rise in platelet count over 30,000 and 12.5 days for a rise in platelet count over 50,000. So this is a drug that gave you a very high response rate, very rapidly, and very durable. Whether you had prior therapy or not didn't matter. 40% of patients responded whether you had a splenectomy or no splenectomy, whether you had a low platelet count or a slightly higher platelet count. It didn't matter what your primary response criteria was. So then we have an extension study of 16 patients. This is where these are all the responders for the initial study. They then could go on to an open label study, and their median platelet counts here were 87,000, and they continue in the study. This is still ongoing. And what's remarkable about this drug is that platelet counts over 30,000 were maintained a median of 100% of weeks, over 50,000, a median of 90% of weeks. So basically, the ITP for almost all patients was well controlled for this ongoing study with a median duration of almost 500 days. I don't want to spend time on this, but side effects were minimal. They're low grade, primarily diarrhea and nausea. So this is a interesting new therapy that may be developed in the coming years. It's probably the hottest new drug I can think of for ITP. The other hot new drug is this, which is all-trans retinoic acid. This is another abstract presented adjacent to the one I just showed you at ASH. And this is basically a study that takes advantage of the fact that Atra is an anti-inflammatory molecule that reduces cytokines and chemokines. They compared low-dose rituximab, 100 milligrams weekly for 6 weeks, to that same low-dose rituximab with Atra added for 12 weeks. These were patients who had both early and chronic ITP with platelet counts over 30,000. And here's their little bit of a weak endpoint. Did the platelet counts rise over 30,000? Again, this is a not accepted international endpoint, but I'll just show it to you. Quite interesting enough, they have 56 patients on this very low rituximab dose, 112 patients with Atra. The response rate with Ritux was 59%, which is what you expect. This is an overall response rate, platelet count over 30,000. Again, a weak endpoint, but it's not bad for this kind of study. Adding Atra, it went to 81%. What's more interesting is if you look at 6 months, was the platelet count maintained at 6 months off of therapy? Rituximab gave you about a 41% response rate, which is about what you expect. Adding Atra, again, only for 12 weeks, this response went to 61%. Adverse events were, it says rare here, but I'll be honest, they had a lot of skin problems with Atra, as you do if you've used this drug in CML. So to summarize, and this is my last slide, my voice has surprisingly lasted, and the snowstorm outside has put another half-meter snow down. Summary right now is that ITP is an interesting disease where standard care works pretty well for most patients. And I'll simply say there's a very high response rate of 80 to 93% of thrombopoietin receptor agonists in early disease. Another truism, I think, is that a third of all newly diagnosed patients undergo remission without need for a splenectomy, and we should probably give them a medical therapy, rituximab or a TPRA, to allow them a chance to go into remission. I would simply say that the benefits of treating early ITP with a TPRA is the same as for chronic ITP patients. They have the same reduced bleeding rate and lack of need for rescue medications. You can eliminate or reduce concurrent ITP medications. I didn't show you much data, but there's also an improved health-related quality of life with using TPRAs. It's the same in early ITP as in chronic ITP. What I think is interesting, and I want to say this in a critical fashion, remission rates in adults ITP are interesting now because we never really thought about this before, but at least 1/3 of adults will have what's called a treatment-free remission at 1 year without splenectomy. Probably another 1/3 to 1/2 will go into remission in the next year or so. So basically, about 3/4 of patients will have a remission of some type without need for splenectomy or any therapy at maybe 1.5 years. Furthermore, and I think this is to me the most exciting thing that I'll talk about, is that there are lots of new ITP therapies being developed, some for early disease and some for late disease. I think we're going to find, like in oncology, we're going to add more treatment up front to patients. And we have new novel therapies that can be used for that point. And this is a very interesting area ongoing. And I think over the coming years, we're going to find that our already good therapies for ITP will only get better. On that, I'll stop and thank you for your very kind attention. I've enjoyed seeing you again. I wish it was in person. Thank you.
Thank you very much, David, for a very fascinating presentation. And we have heard you many times, but every time we hear you, we learn more things, and refreshing the other memories and also learning new things every time. Very, very interesting. Not only that, but the presentation is so clear and so crisp. It's so fascinating. Thank you very much. We'll take questions after the case presentation. So we'll let Dr. Amar Lal is a consultant hematologist at Tuam Hospital. He is a case, Amar Lal always has some cases up his sleeves. So let's see what he has this time. Amar Lal, please wait.
Thank you, Dr. Marashi. Nice opening, nice introduction, and thank you for inviting me to present a case. So sharing our local experience. So good evening, ladies and gentlemen. In next 10 to 15 minutes, I will take you our real world experience case, how we use guideline, how we make a diagnosis, and how we go smart sequence of therapy. As David has mentioned, there are so many therapies are there. So this is how we'll go. So first is eye opener, which guideline we use actually in all hematology and oncology. And everybody agree that we have these 4 guidelines, but what we use for ITP, we use ASH guideline. So how they go by panel information, then clinical questions, then evidence-based, they make some recommendation, which they have met, and we'll use those guidelines in my case. So first thing is to make an accurate diagnosis. So I will go through this case. This is my real case, 43-year-old male. It was about 8 years ago when he was referred to us from one physician actually, who was incidentally found with the CBC, with the platelet count is 50,000. Otherwise, he was asymptomatic and he has no any concerns of bleeding. And there was no additional finding on the exams. And he has no any past medical history, no medication. So he was referred because of 50,000 platelets. So the question is how to make a diagnosis. So what is the key to make a diagnosis? There are options. We can go imaging, we can go invasive procedure, bone marrow, or simple test, or some blood test. The key is that to check examine the peripheral blood film. Why? The important thing is first you have to see, to smear, to rule out it is not pseudothrombocytopenia. As with the ETT bottle, you always find some clumping, and that is not picked by the electronic particle counter. So you can use citrate bottle. This is one thing. And second thing, if you see in the ITP patient, you will find large platelets. So make a diagnosis by simple test of smear. And as per ASH guideline, you can rule out any infective immune phenomena by these test panel of the test. So this is, a guideline which they mentioned for all patients. You have to go history, physical, peripheral film, and you can check, immune and infective process. So in this patient, actually, we have gone through. So we found in peripheral film that if film shows no platelets clumping and no other morphological abnormalities was seen. So this was typical isolated platelets with the large platelets. So, and all the tests, immune and infective tests were also unremarkable. So what was the diagnosis? Diagnosis was the ITP. Now we have diagnosis. So second thing is what to initiate with this patient. Should we treat the patient or we refer back to the physician? So as at this point, what is the next to best option of the treatment? To start the prednisolone, to discharge the patient back to the physician with the thankful for referral, or you will keep the patient with the monitoring with you, or you use dexamethasone. So I actually discharge the patient back to primary physician for annual lab workup if anything happened, and I just label ITP, then patient can to refer back to us. So this was the first step. Now, this is about ASH guideline. Why you have seen that ASH guideline saying it is against to use steroids if the platelets count is more than 30. So best thing is observation. So this is good practice statement, which we use in this patient. Now, after 1 year, same guy who came in the ER with the history of blood blisters in his mouth and also in arms and legs. And further history revealed that he feels currently more fatigue than as usual. And examination, we found he has petechiae and ecchymosis. And his CBC revealed platelet count is 15 and hemoglobin is also 10. Now, question is, how should you manage his severe ITP with bleeding at multiple sites? So you have option. Will you do same thing which we did before, observation, or use prednisolone, or you will admit and send the patient home, or hospitalize the patient, or you use TPO agonist as a first go. So it was 10 years ago, as I mentioned about. So I admit the patient and start the treatment with a steroid. Why admission? We will see now. What is the NCCN guideline? ASH guideline say? So ASH guideline divided into, again, 4 categories. As I mentioned, if platelet count is more than 30, observation, which I did in this patient 1 year ago, sent back to home. If platelet count is 30,000, I will start with the steroid with the 6 weeks of the duration. It's not months, 6 weeks. And if platelet count is less than 20, you can admit the patient depending on the whole scenario. If more than 20, you can send the patient as an outpatient. So as I mentioned, this platelet count is 15,000 and multiple site bleeding, I admit the patient. So this is same ASH guideline. So what initial treatment? You can use either prednisolone or dexamethasone. It's up to you. Both things are fine, but dexamethasone pulse is faster and higher initial complete response. Otherwise, both have the same efficacy. However, in this patient, it was used 6 weeks of the steroid, then tapering. But the thing is, again, the patient had the disease came back. Here you can say it went down up to, again, 10 to 15,000. Now, the question is, what is this? This is, we label this patient as relapse or refractory disease. I would label this patient as relapse ITP. Why? Because it has initial response, and again he relapsed. He relapsed, so that's why I label this patient as relapse disease. Now, question is next, as David Cotter mentioned, the important thing is what is the treatment, subsequent treatment. Now, what are subsequent treatment? We have 1 surgical option and 2 medical option, rituximab and TPO agonist. So what should we do? If you go again through the ASH guideline or previous guideline, they mention all 4 categories you can use based on the evidence. But which one? It is very difficult to choose. Recently, they have done very nicely. As Dr. Couture mentioned, 3 to 12 months is the initial and persistent ITP, and here is the chronic ITP. So we are here in this category of this patient. So what you have to do, you have to discuss with the patient. Patient places high value on achieving durable response, give TPO. Patients have high value on the avoiding long-term medication, you can give rituximab. So now this patient actually chose eltrombopag, but unfortunately he couldn't respond. Maybe he was not taking drug properly. With eating something is very difficult on ACYs 2 hours before, 2 hours after. So it was difficult for him to maintain the platelet count, and he continued use rescue medicine of steroid for a longer period, 2 weeks, sometimes 4 weeks. So now what is the next thing? What we should do? He was actually frustrated. The option is now either take out a spleen or rituximab, or what is the other options? So now more than 1 year of the diagnosis, we label this patient as a chronic ITP. So after discussing the patient, that patient places high value on avoiding long-term medication. As I mentioned, now patient become frustrated by using continuous therapy. So he want either rituximab or splenectomy. So what we should do, as is mentioned, rituximab is what? Just blast the B cell, get rid of antibodies, and ITP will give some remission up to 20 to 30%. So we thought better to use it now before the splenectomy to take out the organ. It was done, but again, it was good response, but again, the response went down. So what is the next option? Now, again, the next option, we have to take out organ. Or as David Kutter mentioned, there are a lot of other options. You can use MMF, you can use danazol, azathioprine, and some drugs which are still not available, fostamatinib and vincristine. So many medications are there. So what we should do in this patient now? After long discussion, so again, going to the ASH guideline. So the patient wants durable response. Now we have 2 durable response. At this time available, you take out the organ, or you can use another TPO agonist. So and here is the splenectomy. You have seen by Dr. David Kuteras that we are not optimized. Splenectomy is rarely needed. It's going down because of a lot of options are available. So it was, and there because of a lot of options, which was mentioned by him also, fostamatinib and danazol, some immunosuppressant medication, and some combination of therapy. So anyway, in this patient, we used romiplostim, and after romiplostim, he maintained actually platelets count very nicely over the 2.5 years actually. Now the thing is, what we should do, as Dr. David Kutter mentioned, in our part of the world, we should stop therapy as well. So what is the good idea? What is the next option? Can we stop therapy in this patient? So again, the burning question is, which TPO agonist is the rapid responder, long-term efficacy, and which TPO is having the durability and discontinuation data? All the TPO, as Dr. Kutter mentioned, that they have almost same efficacies. Somehow, romiplostim has shown the treatment-free response. They have more data, about 50%. So in this patient, what we should do, there are 3 options I discussed with him. We can gradually taper off. Instead of 1 weekly, we can make it 2 week, like romiplostim, or discontinue immediately, or don't taper off. So there are 3 options I discussed with him. He agreed to stop therapy after 1 month, 2 weekly, then off. So he off therapy. Now he's off therapy over the 2.5 year more. He was doing great. So he had remission after romiplostim. Now, this is sustained response of this medication. Now, year came 2020 when we were facing viral infection. Then, he came to me, what should I do at the end of the 2020? Should I take a vaccine or not vaccine? I said, yes, you should take vaccine. There is no problem. If anything problem happen, we are with you. So, because based on this data, you can see some people are scared that may cause thrombocytopenia, but data indicates there is no problem because 11 per million doses of thrombocytopenia even happen with the flu and MMR vaccine. So similar, and in other vaccines like hepatitis B, also 10 to 30 cases per million doses as well. So it is similar to this one. So we use this patient. So he used vaccine, but unfortunately after 2 weeks platelets dropped. So now what we should do, the next option. So now we have all these things. We can start with the steroid, IVIG, or again TPO agonist or rituximab. Rituximab is out of the question. Only option is TPO agonist. He has already used it. So I use same romiplostin, and within 2 weeks you can say his platelets jumped up. So he respond very nicely. And again he used romiplostin about 3.5 months. Then we taper off first weekly, then 2 weekly, then we stop therapy. Now story finished about this patient, and then he was well 3 months. So this is the bonus question about this patient. What do you think? I hit the disease or I hurt the patient because of going through this? And I think I hit the disease by giving the proper sequence and proper stoppage. There is still one $6 million questions about this patient. Very interesting. This is very practical. Now, this patient has left our part of the world, and he's living more than about 9 months in Europe. And he called me back with his communication with the physician as well. Should I take vaccine or not vaccine? This is the question. So I read a paper from the David Kucher that he encouraged the patient, yes, you can take vaccine because the risk is lower as compared to the benefits. So I told him, take vaccine, no problem. Then what happened? Platelets dropped to 1,000. It dropped, now again suffering. His physician called me again, what you used him before? So I used him romiplostin. He again restarted romiplostin. Again, within 2 weeks, the platelets went up. Now over the 2 months, he's maintaining the platelets count. So by this end of the our local experience, you have seen what I emphasize. I emphasize how we use the guideline to make a key to diagnosis of ITP, how we initiate and what is the goal of ITP treatment, how we use subsequent management, SMART sequence, and what is the win-win of romiplostin and correlation of the vaccine with the ITP. And this is my final. So thank you very much. If any question, I will be happy to answer this. Thank you very much.
Yeah, thank you very much, Dr. Amarlal, for a very nice case, actually. And this is interesting because I have just a young man we have had about a month ago. He developed severe thrombocytopenia within about 1 week or 10 days of the Pfizer vaccine. So I know this is something uncommon. We have discussed with Dr. David Kucher before, and we are encouraging our patients to take vaccination, but of course, this is something that can happen. The vaccination does actually increase the risk. So we will go to the panel discussion now and questions. Thank you very much.
Can I have a comment, please?
Yes, please.
Yeah, I would like to thank Dr. Mahmoud and Dr. Kuter and as well Dr. Lara and other panels for this very nice, interesting discussion. And I would like to start with what my colleague Dr. Lal mentioned about vaccine or no vaccine. And in our patients, in the early era of the pandemic, where we don't know exactly what to do, we recommend for all of our patients to take the vaccine because it's a new era. We are not sure about it. But what we did, we were emphasizing on our patient safety. So we have more frequent follow-up for our patients. And what I saw in our patient that we have at least 10% of the active patient or ITP already on treatment, they develop what this patient developed, that they came down with a single fever, they require visiting to the emergency, and they require rescue medications. So it was interesting to look for the rest of the patients on medications, what happened to them. So we are still reviewing our data, but we have completed more than 200 patients review charts. And we have 2 types of vaccine. We have a Pfizer vaccine and we have Moderna vaccine. And we found that the patients fall into 2 classes. The class 1, which is a patient relapsing, frankly, visiting the emergency. And what was interesting in the rest of the patient that even those they didn't visit the emergency or they didn't got symptoms, they have a drop which is variant from 30 to 50% in the baseline platelets. So if you have somebody platelet, he was in remission and maintaining platelet around 150, we saw in the follow-up, those patients, their platelet after the vaccine dropped, it goes down to 100. Some of them, it goes down below 100, but because it was in the safe level, it means above 50, they didn't require visit to the emergency, they didn't require. Does it came back to normal? Some of them now followed for more than 1 year, and it doesn't touch the previous baseline. So I want to have some discussion around these observations, which we are still looking for, and we are gathering the data just to publish it, because I think it's very interesting to look for the effect of different type of vaccines and the decrease in the platelet count, because we want to look for predictors for our patients. We want to have a clear recommendations, and we want to know who is the one who will fall to single figure we should not give, or maybe we have a different strategy. And those have a drop, but it's like 30 or 50%, but it's still safe. I would love to listen from the panel for their experience and real world data, and if Prof. Kotar also have an insight on this.
So very interesting, because this is an important, we have discussed this as Professor David Kotar. In Amar Allah's case, there's definite, because this is twice it happened. So this is not coincidental anyway. So maybe my patient is a new patient, maybe it is coincidental. So we let David Kotar, because he is the one with the highest experience in this, so we'll let him give us his experience, yeah.
Yeah, well, first, I was a very, very interesting case, and I enjoyed hearing the discourse. It was very, very nicely juxtaposed with my presentation, so I appreciate the overlap. It was very nice. But you know, the vaccination issue is a hot issue. It started on January 12th of 2020 when that patient in Florida died from new ITP or supposed ITP, and all our patients went crazy in the United States. And we recommended everybody get vaccinated, and we then followed their platelet counts. We got platelet counts 3 to 5 days before and 3 to 5 days after. We've now done this in almost 400 patients, and we're not going to analyze the data because I've already published the first 50 patients. The next 500 patients show that 10% of patients drop below 30,000 and require some rescue therapy. The good news is that everybody who needed rescue therapy, and we used prednisone for everybody, all except one patient responded within a couple of days to the prednisone, and things came up. So I think right now the risk of a significant low platelet count is about 10%. You're right. There is a larger group of patients that drop a significant amount, but not to dangerous levels, and they sometimes don't go back to their baseline. Interesting enough, there's another publication that's headed by the group in New York City that it'll be published in Blood very soon. It's published as an online article that showed that some patients actually raise their platelet count. About 10% of patients rise their platelet count after a vaccine. But to me, the question comes, like Dr. Lal's patient, is what about the second vaccination or the booster or the fourth vaccination? And, you know, I would have done exactly the same thing. I would have given this patient with a normal platelet count the second vaccination. I would have checked the platelet count 3 to 5 days after. And if the platelet count was dropping, I would, in that case, probably put the patient on steroids, rituximab, I would not use rituximab. A TPRA would certainly be fine in that situation as well. But I think right now, the question for Dr. Lal's patients, what about the booster vaccination? I'll be honest with you, I would give this patient the booster vaccination, and I might put the patient on Rimipilstim before the booster vaccination to put the platelet count up at 400,000 for a couple of days before giving the vaccination. Now, having said that, I have other patients where they crashed on the first platelet count, first vaccination, didn't crash on the second, third, or fourth vaccination. And the other thing I'll say is that most of the patients who have crashed to a low platelet count for me also crashed with the Neisseria meningitis vaccine, the shingles vaccine, and other vaccines. So 2/3 of my patients who crashed with the COVID vaccine also did the same thing, other vaccinations. So that's my one predictive variable. So if a patient has crashed other vaccines, I'm very cautious, and I'll try to run their platelet counts to a higher level before vaccinating them.
Would you use a different vaccine, for example?
I don't know the answer to that. Maybe you're going to have the answer for us, but I think right now we've only we've pretty much only had the Pfizer and the Moderna vaccines in our area, and we've seen with equal prevalence the drop in platelet counts. We don't have any of the retroviral-based vaccines that we come. The Johnson & Johnson vaccine, we have little exposure to that in our part of the country. But again, I'm not certain that the international report, the VAERS, VAERS is the vaccine reporting thing for the United States, has not shown a difference in thrombocytopenia between the different vaccines, but may not be true for the rest of the world.
So,
But,
Dr. David, you solved my problem. Actually, that European guy, he's one of the good leading physician also. I send him your paper. I say this, ask him. So maybe he will ask you. You are the responsible.
Well, so I, that first paper we published, we said we were reluctant to give vaccines, but as the pandemic has gotten worse, we have changed our view, because I have a lot of patients, ITP, who've gotten COVID, and that makes the platelet count even lower, and it gives you more trouble. So I think that, it's a no-win situation. You either cause thrombocytopenia from the COVID infection, or you cause thrombocytopenia to the vaccine.
Yeah.
Remember, vaccines are very potent stimulators of the immune system, because they have a thing called an adjuvant added to the vaccine. It's the mRNA itself is a huge adjuvant, and many of the vaccines contain lipopolysaccharide, which is an additional thing that stimulates the immune system. So I think I am concerned about my ITP patients, but the good news is 90% of patients do fine.
What about your patients?
The same thing?
What about your patients on TPO agonist during the COVID pandemic? Did you see any increase venous thromboembolism in comparison to the normal population?
No. We've looked, and again, we're about to publish as well. We've looked for patients who've gotten COVID or on a TPRA, haven't seen any increased rate of thrombosis. In general, most of the people who get COVID with ITP have done very well. We've not had anybody die or have to go to the intensive care unit. And there is data that has been published by us with Dr. Bucell and others that shows that if you've had your splenectomy, there's a 2.3% increased risk of having getting COVID infection. And that's based upon a huge database analysis. And you got to be careful database analyses, because they don't have the accurate diagnosis there. But I think this is a issue, but it's the real issue is if you crash the first time, do you give a second vaccination? And I think the honest answer is that you should probably do it with caution, and if you can, with some kind of preventative treatment or at least monitoring. But again, half of the patients who were revaccinated did not have trouble with the second vaccine. So it's a very hard thing to manage. But certainly your patient, Dr. Lal, with the booster vaccine, I would probably give them end plate before the vaccine to get their counts up.
I request company, please give me this recording of David. I will send. Thank you.
But the other thing I'll say is that this is one of the we've had the more trouble with the opposite problem, which is we have patients coming to us who have been given rituximab for their ITP like 6 months ago, and it's something I don't like to do unless I'm desperate, because it prevents vaccinations entirely. None of my patients who, we and others have published this, that within 6 months after Rituxan, there is zero response to a COVID vaccine, zero response. And that oftentimes goes out for 1 year.
So let's go to the discussion point. What are the local challenges you have in ITP diagnosis? Do you have any challenges? Let's see, Hassan, do you have any challenges?
Okay. Actually, for diagnosis of ITP, it's thank God it's easy. So we do, of course, blood film, and we sent for coagulation profile blood film, as Lal said, that we have to exclude pseudothrombocytopenia, especially in a patient who is non-bleeder, who is not bleeding. And then we sent virology screen, HIV and hepatitis C. We do send for our patient thyroid function tests, of course, and the liver function test. Sometimes there is some prolongation of the PTT. We send for lupus and the Coombs test. So there are no major challenges regarding the diagnosis of ITP, but probably there is some challenges regarding the treatment. Testing for H. pylori is not necessarily done, but sometimes we do it. And personally, I haven't seen any patient tested positive who underwent remission after eradication of H. pylori. So this is how we diagnose ITP, and no major challenges regarding that aspect. But in the treatment, yes.
Let's take this point with Dr. David. H. pylori, actually, maybe I've seen one patient who responded to eradication, but we haven't seen. What is the experience in your case? What is the experience in Qatar? We will come to both of you.
I think it depends upon H. pylori strain. And if you're in Japan, 25% of all ITPs due to H. pylori infection. So in Japan, this is a common form of ITP that's readily fixable. That's probably also true in Jamaica and in Italy. And we have analyzed about 10 years ago, 450 US patients with H. pylori infection and ITP, and found that no one responded to H. pylori eradication with an improvement of their ITP. So I think it's a strain-specific problem. I've personally never seen anybody, and I don't test for it anymore unless they're coming from Japan. I've never seen anybody respond to H. pylori therapy. Now, obviously, we're going to find someone who will that I've missed, but it's not something we put in our testing algorithm. I think it depends upon the part of the world you're from.
Mm-hmm. Mohammed Yassin.
Yeah, I think we don't have a difficulty in diagnosis of ITP, but there is always some controversies and challenges. One of the challenges is diagnosis of ITP is a diagnosis by exclusion. And in our area, maybe in the Middle East and North Africa, we see a lot of adolescent and young adult. And we have a lot of autoimmune disorders. So autoimmune disorders also are diagnosed by criteria. And one of these is lupus, SLE. So SLE is presenting with the hematological manifestations. We saw a lot of patients were excluded all other conditions and they were labeled as ITP. And at one stage and on follow-up of those patients, we discovered that those patients, they start to have the full-blown picture of SLE. So we always educate our fellows and colleagues that you have to be open-minded. And maybe the treatment doesn't differ initially, that you will give a steroid as first line or other immunomodulators, but maybe you are treating a different condition. What you think is ITP is not always an ITP. The other area which we face with a colleague and whether to do or not, most of the guidelines are not in favor of doing the bone marrow, unless in certain conditions, if you have an elderly patient, somebody going for splenectomy, or so we have a certain criteria. But some of the colleagues insisting in doing the bone marrow for patients suspected ITP, even though all the other manifestations are excluded. And some of them insisting of doing the bone marrow if the patient fails 2 lines of therapy. So I would like also to listen from Dr. Kuter and the panel, what is the real practice in other countries?
Actually, I want to add one point to Dr. David Kuter. Before going for splenectomy, would you recommend the bone marrow?
Yeah, I'll let me touch on that for a second. I think right now, let me just go back one step further, which is, what should be done in terms of the initial diagnosis. I think that we've already talked about the general things one should do, which is to obviously look at the blood smear. And unfortunately, this requires a microscope. Many of us have the Sysmex machines or things that count the blood for us and flag platelet clumping. But to be honest with you, oftentimes those machines miss platelet clumping. So it's important to look at the blood smear under the microscope and not use the image analysis systems that sometimes are tagged on to the modern Sysmex machines. So use a microscope. I know you guys all have microscopes. That some US people just look at the automated report and you miss pseudothrombocytopenia. Second of all, I think it's important in patients to check a serum protein electrophoresis or a quantitative immunoglobulin level to see if patients have CVID. I'm surprised how common that is in some patients. Thirdly, I agree that a lupus panel and maybe an anti-thyroid antibody panel help us look for secondary ITP. The real challenge, I think, is the one you raised, which is when do you do a bone marrow biopsy? And I would simply say right now that even in a patient who has ITP, if you show me in a blinded fashion a bone marrow biopsy versus 20 other bone marrow biopsies that I don't know the diagnosis of, It's very hard to diagnose IT. It's very hard to diagnose IT from bone marrow biopsy. So I'm going to simply say that even the increased megakaryocytes are very subjective for a hemato. I'm trained in hematopathology. As a hematopathologist, I have a difficult time distinguishing ITP from non-ITP. So when do you do a bone marrow biopsy? I don't think it ever needs to be done at the initial diagnosis and in someone who typically responds. But in someone who doesn't have a typical response, like fails two methods of IVIG and prednisone, it's reasonable. Picking an older patient, for someone who is about to have a spleen taken out and has not had a typical response to other therapies, it's also reasonable. But those are the only two situations where I think it is an important technique to be done. Two other challenges to diagnosis. One is the pediatric patient who comes to you as an adult who says to you, I've had ITP since I was born, and it's been treated like ITP. They have congenital thrombocytopenia due to genetic mutations. 1 in 100 patients who comes to me for ITP that's longstanding has a mutation that's a GATA1 mutation, GATA2 mutation. There's a whole list of mutations that can cause these macrothrombocytopenias, which the Italians did very nicely. Dr. Balduini has elaborated. And we have a panel for gene diagnosis for macrothrombocytopenia, which is very helpful. So in the longstanding pediatric patient, a genetic panel to assess them, maybe not a bone marrow biopsy, is helpful. The major challenge to me is the 85-year-old patient who is thrombocytopenic, who may have an increased MCV, is a little anemic, may have MDS, and has not responded to steroids. Those are the patients who I think probably have MDS. But the problem you face with MDS, even a diagnosis of MDS, many patients with chronic myelomonocytic leukemia will have ITP. So to be honest with you, it's in certain patients, unless you're going to treat the MDS, it doesn't pay to do the bone marrow biopsy in an older patient. So that's a very detailed view, but in general, no need for bone marrow biopsy unless it's an atypical case or does not respond to typical therapies.
One point is a direct Coombs test. If you do it and you find it positive, even if the patient is not anemic, does it change your management? Would you at this point think
we've published a paper on this a couple of years ago, and basically we have done in about 150 ITP patients a whole immune panel: anti-thyroid antibodies, anti-phospholipid antibodies, lupus anticoagulant, ANA, Coombs test. And what we found is about 25% of patients had a positive ANA or a positive Coombs test, but did not have lupus and did not have any warm antibody hemolysis. So I think right now, unless someone has obvious evidence of hemolysis, the positive Coombs test may be interesting that they might evolve to Evans syndrome, but unless they have hemolysis, I don't do anything about information. I treat them like ITP. There is one thing I'd say, that if you do have a patient who has, and again, I think Mohammed, you brought this up, the primary ITP versus secondary ITP. So the lupus patients are the main ones I would think about here. Oftentimes treating the lupus makes the ITP better, but sometimes the lupus is so mild that it's just simplest just to treat the ITP. But those are the patients who I worry about for thrombotic risk. So if someone has a bona fide diagnosis of lupus and has a platelet count, say, of 15,000, I might prefer rituximab in prior years to a TPRA in that patient, just to avoid the thrombotic risk that might be accentuated by a higher platelet count.
Can I take you, David, on one point? Somebody like that has got positive lupus tests, but the main manifestation is thrombocytopenia. Now, do you see them progressing, and what's the percentage where they're progressing to frank lupus with other symptoms?
Well, again, like the case we heard a few minutes ago, some progress, but most of our patients have not progressed. I have a database of almost 3,000 ITP patients I've seen the past 40 years, and we actually went back and did some not very good analysis that the patients with lupus anticoagulants and positive ANA tests that we diagnosed in 1985, we didn't find that they had progressed to lupus. So I think right now, progression is uncommon. But remember, the Middle East, as you nicely said, there's a lot more autoimmune disease in your part of the world than my part of the world.
Yeah, sure.
Professor Kutar, you nicely mentioned the pediatric group of patients who then present as adults. We in our region, we have some adult patients attending to start with thrombocytopenia, which is not severe, in between 100 and 150, which is not matching the WHO definition of ITP. And when you take family history, it is negative. When you screen them for all the other causes, it is negative, no evidence of any immune disease, no evidence of any viral infection. Their blood smear is normal. So where do you put this group of patients? And of course, they will be just observed, but what do you tell them? Do you have immune disease?
Yeah. These are patients whose platelet counts are over 100,000 and are sort of in the between 100 and 150,000. Is that right?
Yeah.
Okay. Yeah. I pretty much tell them that Dr. Roberto Stasi 20 years ago evaluated this group of patients and found that only 3% evolved ITP. So there's a very low conversion rate to frank ITP. I will say they probably have an autoimmune process. And like many ITP patients who are in remission, and let's go back to Dr. Lal's patient who I think had a platelet count that was 150,000 or so. That patient still may have increased platelet turnover, meaning that they're still destroying platelets, but they're compensated. So my view of these patients who have an autoimmune characteristics and have platelet counts of 120,000 is they may have very mild increased platelet destruction, but they're compensated. And that's what happens in hemolytic anemia. A lot of times people have a positive Coombs test. They have a high LDH, a low haptoglobin, but a normal hemoglobin because they're compensated okay. So I would tell that patient they probably have an autoimmune predilection and that their chance of having worse disease is probably pretty low. And if they needed a COVID vaccination, I'd probably recommend a platelet count 3 to 5 days after they had their vaccination. But I do think that they have some autoimmune process that's affecting platelet lifespan.
Right.
Yes. Can I ask another question, which something which we face in our practice, that we have a lot of females in a childbearing age, and they got pregnant.
Yep.
And in pregnancy, we see a very different course in ITP, but most of them, they require treatment throughout pregnancy. What we do usually first and second trimester, we go for steroid or IVIG. And of course, we have to take in consideration the patient choice. What about the third trimester? Because also this is an area of controversy. On myself, I used TPO agonist for many of my patients, and they did very well. Some of the colleagues, they are against using the TPO agonist, and they continue on IVIG or steroid. So what is in your practice, and what do you see the evidence in pregnancy?
So what I say to you was two things. One, I'll give the answer in a second, what I think. But if you have an experience of using TPRAs in pregnancy, you should put it together and write it up, because we are trying to collect cases from around the world right now to try to see what the experience has been globally. In terms of the drugs one could use in pregnancy, I am very much against using L-trombopeg and avatrombopeg, the oral agents in pregnancy, because they have a lot of off-target effects on other things, including iron chelation. So if I'm going to use a drug during pregnancy, which I have rarely done, it would be romipilstim. So the first point I make is that I don't think that they should be used, but occasionally they need to be used. The real question is, what do you do during pregnancy? So there are two parts of pregnancy. One is the baby's in the mother for 9 months, then you got to get the baby out. So we are willing to accept, and I've got 3 pregnant patients right now, a platelet count of say 18 to 20,000 in the absence of bleeding, and we just don't do anything during the 8 months of pregnancy. So this is a lady I've taken care of right now. She's on no therapy at all. She does respond to corticosteroids, and our approach to delivery is we're going to put her on corticosteroids of 40 milligrams a day next week in preparation for her delivery in 3 weeks. And her platelet count will probably go to that magic number of 70,000, where she'll get epidural anesthesia. I have another lady she's a Ashkenazi Jewish lady who's Orthodox, and she has had 11 children. Okay, number 12 is about to come out. that labor is going to last 30 minutes. Her platelet count is 22,000. We're doing nothing. She'll have no troubles bleeding because of that platelet count. She's got huge platelets and she may be having an episiotomy and she's not bled before, and we're going to do nothing. The real challenge is a patient who's now at 5,000, one who's severely thrombocytopenic. Those patients are treated with corticosteroids during pregnancy to get the counts to 20,000, or episodic IVIG if necessary. And in preparation for delivery, those patients will get a course of IVIG before the delivery date to allow a platelet count of over 70,000 for epidural anesthesia and a count of, say, 20,000 if we're not going to have epidural anesthesia. So I think our goals are modest in pregnant patients. The good thing about women is they're built not to bleed. And as you know, women clot with pregnancy a lot. So we've seen very few patients have troubles of bleeding with a normal vaginal delivery at platelet counts of 20,000 or 15,000. That's not perfect, but I'm trying to say is that that's acceptable. The issue is epidural anesthesia for pain control. There's no anesthesiologist I'm aware of that will let you go that way without with a platelet count of under 70,000. So that's the usual challenge. So coming to your issue about, you know, what if it's month 8 and my patient has a platelet count of 9,000 and doesn't respond to steroids and doesn't respond to IVIG, would I use a thrombopoietic agent? Yeah, I would. I'd use Ramipelstym at a dose of probably 3 micrograms per kilogram, and we found that that works quite well in most patients. But again,
rituximab in pregnancy.
Yeah, so yeah, there's no problem. There's no trouble in my mind for rituximab in pregnancy. I've given rituximab to patients with lymphoma during pregnancy. The problem with rituximab is it doesn't last for very long in half the patients. So the question is, how do you time it? So if your delivery is next week, it's not going to work in a week. If your delivery is in 2 months, it might work. If delivery is 8 months from now, it might have dissipated its effect. So my real concern about pregnant patients is to prepare them up front for their ultimate pregnancy. So if I got a patient who says, I want to get pregnant, and she's running a platelet count of 30,000 and is on no therapy, I would at that point seriously think about giving that patient a course of rituximab or something in the pre-COVID era to make the ITP disappear.
Actually, the immunoglobulin and steroids may or may not work. And not so sure. I did discuss this with Adrian Newland when he was in Dubai, maybe 6-7 years ago. He has used in the 3rd trimester and he has had no problem. So we have used actually about 6 or 8 patients here. We didn't have any problem, neither we had any problem with the baby, and we had enough platelet to get the necessities to give epidural. So we normally start somewhere in the 35th, 36 weeks of pregnancy to give this therapy.
So what agent was it? What did Adrian say? Was it Ramipelstym or which agent?
Ramipelstym, yeah.
Yeah. I think right now I have, again, we need more data to make us comfortable with that. And I think if you've got some cases and the rest of you have cases, you ought to put it together and write it up, because there are very few good reports. There was one ASH report of using Ramipelstym in pregnancy that was a registry that Amgen, I believe, had sponsored, that showed that there was no harm done. So I would certainly support putting together some data.
So let's go to the next.
I personally don't think it's going to make, the reason why Ramipelstym is not harmful in my mind in pregnancy is because fetal megakaryocytes, the baby's megakaryocytes, are not responsive to thrombopoietic agents. So in the baby, megakaryocyte development is different than in adults. So fetal megakaryocytes don't respond to TPRA. So to me, I don't have any theoretical concerns about getting a Ramipelstym to someone at month 8. I haven't, again, but most of my patients can do without it. So I'm just saying that it's not usually necessary.
So we have a discussion point we have to take. What has changed in your practice of ITP treatment based on the updated ASH guidelines? So we'll let Amar Lal start with this. Has this updated ASH guidelines changed your management practice?
Yeah, actually, updates ASH 2019 have changed. Actually, as I mentioned in my cases as well, the old guideline just put, all the treatment options are there, and there was not sequence actually. At least they have put some smart sequence like, durability, avoiding, discussion with the patient. So it makes a bit difference as compared to the old guideline. So because they have divided durability of the treatment, avoiding long-term medication, avoiding surgery, it's like, open the, I put on the screen, I showed to the patient, you are, this is persistent ITP or you are in chronic. So now you have this table and these are the three options, choose one A, B, C. So, this makes a difference. At least people follow, guideline and, not like Dr. Barashi is treating different, I'm treating different. That is, guideline means give the guide actually direction. So at least update guideline in short, giving us a direction which, treatment should go. Thank you.
Muhammad Yassin, any update the guidelines and they change your mind?
I think ASH guidelines is excellent guidelines. There is no doubt. But what I would like to emphasize on is to have our regional guidelines and recommendations based on our populations. And if you allow me, I will give two examples. Example number one is TPO agonist in our patients. We have studied our patients and evaluated the response to TPO agonist. And as we know, in East Asia, like in Japan, they responded to lower dose of L-Trombobag. They are maintained on 50 milligram. The study which was published. For example, with a medicine like L-Trombobag, we found our patient responding only to 25 milligram, which is saving the cost for our hospital and preventing thrombosis. And in the era of early days of where we start L-Trombobag, we got so many thrombosis because when the patient goes to the standard dose, the platelet is all of a sudden going up and we have a few cases of thrombosis. But on evaluating our patients, we found that among Arab and Asian, 25 milligram is a quite good dose. Also, we have evaluated our patient for rituximab. We have evaluated our patient for riboplastin in pregnancy. And this is my previous question. So what I emphasize on is you have to be inspired by the international guidelines, but regional guidelines are always important because we have the ethnicity makes a difference. The lifestyle of our patients is also different because the lifestyle for people in the Middle East are quite different from the people in US or in Canada. Also the environmental factors. If we are talking about platelet of 30, we have so many of our patients, they are laborers, they are working in a temperature of 50 sometimes. So we have to take, when tailoring the decision, we have to be inspired by the international guidelines. We have to have our studies from the Middle East, and we have to adjust the treatment based on the ethnicity, on the real response, and we have to publish our real world data from this area of the world.
Hassan?
That's very well stated. I agree completely with that. You cannot, there are two things those have ASH guidelines. One is they are something you can use as a guide to your own guidelines. And number two, there is supposedly evidence-based, but at the end of the day, there is no evidence upon which these guidelines were based. They were based simply upon 22 experts in a room who saw all the evidence and realized there was no way to make a statement. So I'm going to be honest with you that they're a good place to start, but for any individual region, you've got to make your own guidelines. That's totally correct.
Thank you.
Hassan, yes, you have anything to add?
Yes, in addition to what was said, I'll just add one factor, which is the financial affordability here in our region. Although probably the guidelines and the trend now is toward putting TPO agonists as a second line before rituximab, but when we compare the cost of ongoing treatment of TPOs with rituximab, and here we are using, of course, 100 milligram dose weekly for 4 doses, and we usually get a reasonable sustained response. If we compare that to the cost of long-term TPO receptor agonists, then we prefer to go for rituximab as a second line, taking into consideration the financial aspects of most of our patient population. So this is another important factor which guides our options actually. Of course, during the pandemic now, using rituximab was a bit, I mean, we used that cautiously in regards to the infection itself and the vaccine. But now, after most of the population did receive the vaccine, so again, what I have said, that rituximab comes probably prior to TPO receptor agonist. Again, this is coming true for most of our patients.
Actually, there's a
It's
question.
important, actually, if I say, I agree with you totally on that, because each region's got to take costs into effect here. And I certainly agree that rituximab may not have the highest response rate, but if it works, it works. And to be honest with you, the ASH guidelines, having been on the committee, the data to support the TPRAs over rituximab were based upon a 1-vote margin as to who felt that was the best way to go. So I would just want to encourage you to say that as an insider telling you how things work, there is no evidence that says that rituximab is any better or worse than TPRAs. The only exception being is the current concern about vaccinations. So I think right now, this is why regional guidelines, which take into account your health structure as well as your patient population, need to be standardized for your part of the world.
So there's a question here from the audience regarding whether you would recommend splenectomy from the cost issue in those patients who have issues with finance because of the cost-wise.
Well, again, this is true for everything in medicine. You've got to accept therapies, and if you can't afford the therapies, you got to go then down the line and take the next therapy. So I would encourage whoever asked the question to at least wait a year before considering splenectomy, because at least a third or half of the patients will go into remission and that requires splenectomy. But if therapy is not available or can't be afforded, splenectomy is always an option, and it's been used for 100 years and it works. There are negatives to splenectomy, but it's not an absolute contraindication. That's never the case.
Actually, there's another question coming through. I think this is from a pediatrician. And would you consider checking for von Willebrand type 2B, because he has had a patient recently who has had thrombocytopenia and turned out to be type 2B. Would that be a consideration for you? What's an all patient or in few patients?
Well, most patients with type 2B von Willebrand's have platelet counts of 80 to 100,000. They don't have platelet counts of 10,000. So that's a patient who would not necessarily be treated in the first place. But if a patient's got a platelet count of 10,000, yes, they might have concurrent von Willebrand's type 2B plus ITP. I've seen that, but most type 2 von Willebrand's disease patients have modest thrombocytopenia and don't require any ITP discussion or treatment.
One question, very interesting that you have shown the results with the romiplostim and eltrombopag, and those patients who stop therapy, they remain in remission. Now, this is far more than those patients who would respond on its own without any therapy. So what's the mechanism of this response and the maintenance remission?
Well, again, I'm going to say two things. One is that I do believe the data that says that using a TPRA has some beneficial effect in terms of long-term remission. I'll be honest with you, I don't think we know the mechanism. So the several mechanisms are, one, like many autoimmune disease, that simply disappears with time. Time heals many things, and it just may be letting the underlying disease disappear. Number two, there are thoughts that raising your platelet count alters feedback loops on what are called T regulatory lymphocytes. And there's data that says that T regulatory lymphocytes are decreased in ITP. And when you go in remission, they go up. And so there is some suggestion that by raising the platelet count, the higher platelet count in turn alters T regulatory lymphocytes. So there's a lot of mechanisms you can sort of play with. It's very hard to prove mechanism here. And I'll just be honest with you, there is a clinical association of response and remission. How it's working, I think that we still have a long ways to go. But I would also put in a statement saying that the newer agents we're developing may be cures for ITP. And I'm not here to put another plug-in for Bruton kinase inhibition or other therapies, even Atra, but immunomodulatory drugs, even mycophenolate, which are available, may play a major role in ITP and mitigate the need for expensive therapies like a TPRA or splenectomy.
Actually, here we use a lot of mycophenolate ourselves, but I will just ask you one question, that when you're using, for example, TPO agonist, does it not make sense that to use an immunosuppressive like mycophenolate additionally, that you're working in two different mechanisms and may need lower doses of both drugs?
You're speaking like an oncologist right now, okay? So, Hodgkin disease was treated with one agent in 1950, now we treat with 4 agents. But the answer is yes, we are evolving with time to add other agents, to have combination agents for ITP. And you're right, it makes some theoretical sense to take an agent that increases platelet production, a thrombopoietic agent, and use another agent, which is an immunosuppressive agent, to decrease platelet destruction. And we and others have shown that adding small doses of prednisone to a TPO agent makes the platelet count go higher. Others have shown that using rituximab, brief course, makes the platelet count go higher. So yes, I think there's a story there. It just, the problem we face is these studies haven't been done. And to be honest with you, the studies will not be done by industry because there's no vested interest for industry to add a cheap agent to an expensive one to make less. I'm not here to be cynical about this, but this is how the world behaves. You know what I'm talking about.
Exactly, yes.
Yes, Mohammed Yassin, yeah.
Yes, what about switching from one TPO to another? If you have a patient who failed 3 lines and he's on L-Thrombovac, he failed L-Thrombovac, for example.
Yeah,
so switch to auremoplastine.
Yeah. So first of all, it's important when you say fail that you've tested the full dose response curve, gone to the maximal dose. If you failed the maximal dose, for example, of L-Trombopeg, we and others have shown there's very good data that switching to another TPRA gives you a 70 to 80% response rate to the new agent.
Okay.
So switching is effective.
David, I just want to, you showed very nicely that in the spleen of patients who failed, for example, even rituximab, you find these plasma cells which are producing the antibody. Does it make sense, therefore, instead of going for splenectomy, to give, for example, a bortezomib or anti-CD38 to kill these plasma cells instead of going for splenectomy?
Yeah, now you're adding even more costs, okay? So yes. The study is being done right now, done by Walid Ghanima in Norway. I mentioned that briefly in the penultimate slides, but there is an ASH abstract about a daratumumab study that he's doing in Europe. I am part of his group, but daratumumab and Velcade have been used with efficacy in ITP. I think these agents will possibly work, but again, they're not cheap agents. They cost a lot of money. So I think right now, yes, there are ways to make plasma cells disappear. There is an experimental anti-CD38 antibody from Takeda that's being studied right now in ITP with that very same view in mind, kill off the plasma cells and make the ITP disappear.
Well, we had a very resistant case of ITP when we gave bortezomib with 2 cases. Also, we have used it in TTP, resistant TTP, and we got the same response that you get a quick remission because you kill the plasma cells.
Yeah, we've done the same thing for TTP and for other and for ITP patients and for warm antibody hemolysis. So
yeah. Another point from your presentation of the BTK inhibitor. Now you're blocking the macrophage. Will it increase the risk of infection because that's probably you're blocking the opsonization there?
Well, so I think the first thing I'll say is that none of these inhibitors are 100% inhibitory. So I think right now, the data so far is we have not had any increased infections. And I use a lot of ibrutinib for CLL patients, and I'm actually surprised how few infections occur in that patient population. So I think right now it's a concern long term, but it hasn't been a concern we've seen so far.
Yeah, very good. Now,
Professor Kuter, Dr. Mahmoud, I have just one question. Professor Kuter, you nicely mentioned that introducing immunosuppressive therapy, for example, like mycophenolate, early in the treatment, and probably this is related to the discussion point which is coming, might reduce the rate of acute ITP going into chronic ITP. But for how long, for example, using immunosuppressive medication or TPO are for how long to achieve this target, for how long we should use that.
Yeah. So I think right now for the mycophenolate issue of preventing early ITP going chronic, the British group have shown that on average people are on mycophenolate for 8 months and then could come off it. But to be honest with you, for remissions with TPO-RA up front, there's that one Chinese study I showed you that had a slight difference in response rates at 6 months. So we don't yet know what the duration of treatment needs to be to create some kind of remission. Those are studies that are underway. I don't have a good answer to your question. It's probably the safest thing to say.
So the other discussion point is, how do you evaluate early treatment in patients with ITP? Or how do you evaluate this treatment? Actually, I don't understand what it actually means. But I will tell you one thing, that actually in our practice, if the patient can afford, and the patient comes with a platelet of 1 or 2 and having severe bleeding, our practice in Dubai is we give mycophenolate, dexamethasone, and TPO agonist. And then we because we don't know whether the steroids will work or not, many times it doesn't when the patient comes to us. So, and then we get off the steroids within 4 days, and then we come down on the 2 medication gradually. And that it gives us a very good response. You think this is something, and we cannot do it in every patient because they cannot afford, but those who can afford, the insurance allows, this is how we go in, and then we go in and step down after that.
Yeah. Well, again, I was going to say that if that patient was in Boston, we would give them IVIG and corticosteroids for 3 or 4 days if they weren't bleeding excessively. So, but that's a very expensive, IVIG is very expensive, as you obviously know. But, you know, I think that for the patient with platelet count of 1,000 at initial presentation is bleeding, the course is to give 1 gram per kilogram for 2 days in a row with IVIG and give them a large dose of prednisone or dexamethasone.
But IVIG doesn't work. It's like, you know, you're a very pretty girl, you're a young man, and you spend all the money on using IVIG, and it gives you a response of 60%, and which is very transient response. Yeah. Then you're left high and dry and nothing to do.
Remember, I live in the United States. We waste a lot of money on lots of stuff. I'm just saying that is how that's currently taken care of, and that's what the current ASH guidelines advocate. But there, as you're doing, you're making a good work. This is where regional guidelines, taking into account resources and patients, that what you're proposing as an approach is totally fine. I have no troubles with that. I have patients who are diabetic who come with a platelet count of 1,000. They're not bleeding because they have big platelets. I will start them on a TPO-RA on the first day, and that's the only therapy.
Yeah, because we aim for a long-term sort of response, so long-term relationship. So that's why the IVIG, because it's so expensive here, it's something like $15,000.
I agree. It's $15,000 everywhere.
Yeah.
But I'm not here. I'm just saying that that's our practice. We live by what we have and what we do, and we probably waste a lot of IVIG because 10 days later the effect's all gone. But I will simply say that we have another hospital cost that we think about, which is each hospital day costs $5,000. So if I give a patient $10,000 of IVIG and get them on the hospital 2 days sooner, it saves a lot of money. So there are a lot of cost differences we have.
Mm-hmm. Sure. Right. There's some question from. This is a patient with a 7-year-old with Fanconi and no HLA identical donor, started on danazol, but has severe thrombocytopenia. Did the TPO have any role in this case?
Yeah, there are some case reports that were reported from Tufts Medical Center in Boston about 5 years ago that supported, that said that the patient would respond. Again, your goal in such a patient is to get the platelet count from 7,000 to 20,000 so they don't bleed. But most patients who are thrombocytopenic from almost any cause will have a response to a TPO-RA. Obviously, this child needs a transplant, but it looks like there's no HLA donor.
Actually, I work with a lot of oncologists, and we help them. Sometimes the patients cannot receive therapy on time because of thrombocytopenia, and we are using TPO agonists and we're able to get them on to therapy on time. Although this is not an approved indication, but we use it in many patients very successfully. What's your impression of this, and what's your practice?
Well, I just finished for a 4-month effort of writing a review on this entire topic that will appear in Hematologica on April 1st, okay? So it will cite our own data, which we've now treated almost 400 patients at the MGH Cancer Center with these TPO receptor agonists. This was published by Dr. Al Samkari and myself about 10 months ago. And what we've shown is that over 90% of patients have their platelet count rise, and this allows chemotherapy on schedule. Now, the problem is, and you know the problem as well as I, is that many of these patients, the chemotherapy is not going to help them too much in terms of surviving. So we may be providing supportive care for a therapy that may not prolong their life. So the real challenge is not so much can get the platelet count up. Yes, you usually can. The problem is it going to make any difference? So yes, the drug will work, and I have no questions. And our favorite drug has been Romipilstim. Less good data from Eltrombopag. And if you're in China, which none of us is, recombinant thrombopoietin has been approved for 12 years for treating chemotherapy-induced thrombocytopenia. There's a wealth of Chinese data, again, describing rises in platelet counts, but not showing that affects the end of, that doesn't affect survival or dose intensity.
Mm-hmm.
But again, we use this routinely.
Yeah, another discussion point, I think we have already covered this discussion point of switching from one TPO agonist to another. So when would you do that? I think you've already touched this point. Yeah. Anybody? Mohammed Yassin, you have
yes,
some?
yes, I have some questions from the practice. The first one is the dose for IVIG. Many of our patients, they don't receive the standard dose. I mean, they didn't receive the 1 gram per kg or 0.5 for 4 days. So we notice even those patients receiving half dose, they have the same response. So does this mean that there is a chance to cut the dose by 50% and to maintain the same response?
This is a great question. I love this because I almost never give 1 gram per kilogram times 2 doses. And I do that for 2 reasons. One is because if you give patients daily 0.4 grams per kilogram for up to 5 days, which is the initial regimen that Paul Umbach proposed in 1984, half of the way through that course, people already have a response. So and the second reason I don't use the large dose is because half the patients develop a headache an hour later and require a CAT scan. So I think that many people will respond to lower doses. I just can't tell you any data that supports saying that a lesser dose is the same as a larger dose. That's a good study to do. It's not been done. What I will tell you, which is really nifty and really interesting, is in terms of IVIG, only 5% of the immunoglobulin you're giving is clinically effective. Only 5% of that big volume you give works. And that's the IVIG that has a lot of sialic acids on it. Hypersialylated IgG is the only thing that works in ITP. There are now companies that are taking IgG and sialylating all the IgG, and that's going to be a super IVIG. That means that you can give, instead of 500 mils, give 5 mils of drug. It's probably going to cost the same amount, but in terms of price. But yes, I think lower doses work equally fine. I almost never use the full dose that you described.
Professor Kuter, I have a question. Actually, this question was repeatedly asked by my medical students. Why plasma exchange is a modality in TTP and not ITP? Although theoretically there are antibodies in the serum which attack, which mediate the immune response. And
my dear friend Adrian Dillon has visited your part of the world many times, as have I, and he did plasmapheresis in ITP some 40 years ago, and it does work. It has a response rate of about 30%. The problem with plasmapheresis is that unlike TTP, which may be somewhat self-limited with therapy, you're gonna have to plasmapherese people a lot. And it's IgG you got to take off for both diseases. But in TTP, you're doing 2 things. You're taking off the antibody, but you're also putting in ADAMTS13. Yeah. So I think the problem is that we're not putting anything in for ITP patients. Now, having said that, as you well know, the neonatal FC inhibitory drugs, which are being tested, and we published on this a couple months ago, they will be the equivalent of plasmapheresis. And so what you'll find is that medical plasmapheresis, which is a neonatal FC inhibitor, will become an appropriate therapy in some patients in the future to make that the antibody that you're concerned about disappear. One of the drugs called efgartigimod has been recently licensed a week ago in the United States for myasthenia gravis because it drops the IgG by 85%. It drops the myasthenic antibody by 85%, and the myasthenia gravis disappears. In ITP, it does the same thing, and it makes the ITP respond. So that's about what I call medical plasmapheresis. But standard plasmapheresis, yes, it may drop the antibody for a couple of days, but 4 days later, you're going to have troubles. But occasionally, there's a bad patient who's in the ICU, nothing works. We've done plasmapheresis to give us a little time for other agents to kick in. So it might be rarely used, but I would probably prefer vincristine in that situation. So I don't think it plays a major role. I don't think it plays a role except in very rare situations in ITP.
Even in TTP now, with the use of caplacizumab, we have actually done one patient without plasma exchange, and the other patients, we have stopped the plasma exchange very quick within 3 or 4 days. So
here's what I'm going to give you. Here's what I'm going to give you a hard time. Okay, so you're using a very expensive drug that you can afford that I can't afford. So we don't approve caplacizumab for our TTP patients because we think it costs too damn much.
Dr. Marashi, I have one small question with the David Couture. I have one patient, actually 30-year-old lady who was diagnosed severe cytopenia, all three together, ANA negative, JET positive. Her platelets always responds to, TPO. Her problem is actually more, leukopenia. ANC goes to 100, 200. We have done everything for her. Immune, infective, bone marrow, Fanconi, PNH. We've done everything ruled out. My question is, rituximab work more in ladies. So, I was just thinking to give her rituximab, but I'm just worried about leukopenia. It may more aggravate. What do you think in this point?
Yeah, I've got a couple of those patients as well who have sort of a pan-autoimmune disorder. This is the disease that Evans described in 1948. Evans syndrome was initially described as having neutropenia, hemolytic anemia, and ITP. And he also had some people who just had ITP, and so there's a whole, you can have many immune cytopenias. If you think this is an immune cytopenia, your options are rituximab, which should work. It might be mycophenolate. It might be tacrolimus. So I think there are many. I would approach this patient with an immune modulatory approach. Rituxan is obviously the simplest drug. I think that if the patient's critically ill and at risk for infection, I would probably recommend giving the rituximab because I also would imagine that she was not going to mount a response to COVID vaccine anyhow. So you might as well recognize that you're going to use the rituxan.
No, she finished COVID vaccine, booster dose finished, so we can give her. I was just concerned, because rituximab sometimes cause, leukopenia.
Yeah, I know, and I hear you, and I've seen that it's about 1.5% or 1.8% of patients in ITP will get neutropenia from rituxan. I would probably say that the benefits outweigh the risks.
Yeah, sure. So, okay, thank you.
Mohammed, yeah.
Yeah, I have a question about, in real practice, we see few patients, cardiac patient coming with acute myocardial infarction, and they have a single figure platelets.
Yep. Oh, well.
And we are rushed by cardiologists to give something. So what is your practice in those patients? What is the best treatment to give for somebody with single platelets, single figure platelets, acute MI, and you are rushed by cardiologists to give something?
So Mohammed, we ought to have dinner sometime together because I love your questions, okay? This is a terrific question. So what I'll tell you right now is that when you have ITP and a low platelet count, this is not chemotherapy-induced thrombocytopenia, this is ITP. You're making platelets at a rapid rate, they're being destroyed. Yes. The platelets you make are big and hyperfunctional, and in a patient who's not bleeding at a low platelet count of 9,000, they're hyperfunctional. So your problem in a heart attack patient is that you give aspirin. Aspirin works for 15 minutes, then the aspirin's gone. The platelet that's been made inactive by the aspirin disappears in 3 hours. So in these patients, I have no troubles giving aspirin. And then I would also recommend giving aspirin every 4 to 6 hours if that's the only therapy they want you to give you. If they want you to do a stent and give them clopidogrel, I have also little concern about inactivating those platelets, because the platelets are so new that oftentimes the antiplatelet agent has no effect or minimal effect. And if it has an effect, it only lasts for a short period of time.
Have you used IVIG for any of those
Yeah.
patients?
So if in that situation, what I do is I tell the cardiologist, do your work, give the person antiplatelet agents. I would give them IVIG to get the platelet count higher. But here's where it's a double-edged sword. You're raising the platelet count, and someone has got a platelet problem, which is thrombosis. So I would tend to, in that patient, give the antiplatelet agents, give IVIG, and recognize that I'll get the platelet count to 30,000, and everybody's going to be happy.
There is some anecdotal about IVIG causing myocardial infarction, and have you seen that in your practice?
There's more than anecdotal. There's actually a very nice paper looking at the thrombotic rate of IVIG. I think, many therapies are not without their side effects. So you got to recognize it. Yes. You can cause some troubles unintentionally, but I would do something rapidly to get the platelet count up, just so that other doctors don't go crazy. Mm-hmm. Because many doctors, including cardiac surgeons, will say to me, platelet count's 10,000. I can't take them to the operating room. And my response is, well, they're going to die of their heart disease if you don't. We can fix bleeding. We can give blood. So I will simply say that your goal should be to get the counts up to an adequate value to allow adequate hemostasis, then let the antiplatelet agents make the hemostasis disappear.
So we have one last discussion point is, how do you to which extent do you involve your patients in the decision treatment choice, and what are the challenges when you do that?
Is that for me to answer? I mean, be honest, I talk a lot to patients. All my patients have my cell phone number. And so when a patient meets me, I will say to them, you have ITP, you're not going to die from your ITP. We have lots of options, and our option is to minimize side effects and to give you a modest platelet count. And I usually say our goal is a platelet count over 30,000, unless you're a world-class athlete. That's all we're concerned about. And, I think right now I tell patients that, this is not going to kill them. I think in terms of treatment options, I've always been a non-British type physician. I've always discussed it with patients for decades, whereas the Brits like to dictate this stuff still to patients. So, my wife's British, so I can say these things, but I think right now the main statement is, I think we all should make the patients part of the discussion from the very beginning.
Our patients generally, they let us choose for them. Give them the choice. They don't want the choice. Yeah.
I've noticed that when I visit your countries. Okay, so.
Anyway, I think we have reached beyond our time, and we don't want to. Your voice has taken you very well, and we are very.
I feel I'm all invigorated. I'm now awake. Thank you. Okay.
Anybody has any questions from the panel? Somebody only answered about, we'll have quick if we want to continue for a few minutes, the role of platelet transfusion when you transfuse. Number two is indication for bone marrow transplant in ITP. I don't know whether these days we ever need that one, but I think it's some question.
Well, again, Justine Meehan Carr in the American Journal of Medicine in 1983 published a paper saying that if you have ITP and are bleeding, if you give a platelet transfusion, it works. The platelets don't live for very long. So there are patients who are actively bleeding, such as a CNS bleed, where we'd give IVIG, corticosteroids, and we give them platelets. So I think right now, in someone who has life-limiting bleeding, yes, platelets will be effective for a short time. In terms of bone marrow transplantation, I've written an article about this about a decade ago. There is a list of about 40 patients who had bad ITP who got transplanted. My suspicion is half those patients had MDS as the cause for their severe anemia, for the severe thrombocytopenia. It is listed in the international consensus guidelines as an option, which is almost never exercised. So I think that there's almost no patient I've seen in the last 30 years who would ever need a bone marrow transplant. So I think we have better ways to treat ITP than transplant.
Of course, yeah. Thanks. I think we have to wrap it up. And really, it was a pleasure and to listen to you again. And we have really learned a lot, and we always learn a lot. And also, we learn from each other, from Muhammad, from Amarlal, from Hassan, and from the question from the audience as well. So thank you very much. And also, I want to thank Amgen for arranging this meeting and Meeting Minds. They have run this very beautifully without any hitches. So thanks to all of you, and we hope to see you again sometime.
Thanks.
Thank you very
My
much.
pleasure.
Thank you.
Good day. Good night to all of you. I'm going to go
Night.
look at my snowfall. All right. Take care, guys. Good.
Okay,
All right,
bye.
thank you. Thank you.
Thank
Good luck
you.
with your snow.
Thank you all.
Thank you.